Good afternoon. Good afternoon, and a very warm welcome to everyone joining us today. On behalf of UP NNF in collaboration with National Health Mission, Uttar Pradesh and Nutritional International, I welcome you all to this special online workshop on breastfeeding and its practical aspects. Breastfeeding is often described as a natural process, but successful breastfeeding does not always happen automatically. Mothers need timely support, skilled counseling, practical demonstrations, and a healthcare system that protects and enables breastfeeding successfully. Today's program has therefore been designed to move beyond theory and focus on practical, real life challenges. Our theme beautifully captures the purpose of today's workshop. I'm Dr. Priyanka, Treasurer UP NNF, and it's my privilege to moderate today's program. We have an excellent panel of speakers representing neonatology, pediatrics, obstetrics, lactation consultants, and public health and program implementation office bearers. So, I would like to invite Dr. Akash Pandita, our honorary secretary of UPNNF. He is director and HOD of neonatology, Medanta, Lucknow. I would formally invite sir to please welcome all the speakers and all the faculty.
Thank you, Dr. Priyanka. Hello.
Yes, sir, you're audible.
So, respected dignitaries, esteemed faculty members, dear colleagues, doctors, nurses, and all the participants who have joined us, a very warm welcome to each one of you. On behalf of State of Uttar Pradesh, UP NNF, my privilege to welcome you today to this workshop, which is on practical aspects of breastfeeding. As you all know, we have been celebrating Breastfeeding Week from 1st August, and it has been our motivation and it has been our effort to make it a success and make it a reality rather than rarity. Breastfeeding is not merely a method of breastfeeding, it is the first vaccine, the first bond, and one of the strongest foundations for a child's lifelong journey. It not only gives him nutrition but also protects a baby against infections, supports his brain development, strengthens emotional security, and safeguards against the health and also safeguards the health of the mother. It also protects mothers against the deadly diseases like cancer, breast cancer, ovarian cancer. Despite knowing its benefits for the baby, for the mother, and for the society, many mothers are unable to breastfeed successfully, not because they lack commitment, but because they often lack timely guidance, confidence, privacy, and support, which we fail to provide. This is where our responsibility begins as a doctor, as a sister, as a family, and as a society. Every mother deserves more than advice. She deserves practical help, a few minutes spent on correcting positioning, attachment, supporting early initiation, and encouraging her for skin to skin contact in the first golden hour of life, or reassuring a worried mother can change the entire breastfeeding scenario, not only of the state, but also of the country. We must also remember that breastfeeding is not solely a mother's responsibility. As we were talking yesterday in a seminar, mother is just a part of it. It requires support from family, from her workplace, a skilled healthcare system, breastfeeding friendly hospitals, job places, workplaces, and communities. Today's workshop is therefore not just an academic program, it is an opportunity to convert knowledge into skill, skill into confidence, and confidence into better outcomes for mothers as well as their babies. Let us move beyond simple saying that breastfeeding is the best feeding. Let us ensure that every mother is shown how to breastfeed, supported when she struggles, and encouraged without judgment. Together, let us make breastfeeding a reality, not a rarity. I sincerely thank all our distinguished faculty members, our GM Child Health, who has taken time from his busy schedule and joined us, and HM for always partnering in important newborn activities for the state, Nutrition International, who have been a backbone of providing adequate nutrition to the babies as well as children, UNICEF, who has always taken a stand and always been the support partner in such activities. And I also thank our Central NNF, our president, Dr. Ashish Prakash, all the faculties, all the members who have joined and taken time from the busy schedule. I hope today's deliberation will inspire each one of us to become stronger advocates and more effective supporters of breastfeeding as a father, as a brother, as a doctor, as a nurse, as a patient, as a society, and in whatever capacities we can. With these words, I once again welcome you all and wish the workshop great success. Thank you. And let us pledge to be a support to a struggling mother and not judge her, but support her. Over to Priyanka.
Thank you, sir. Thank you for that warm welcome and setting the tone for today's academic session. So, it is now my privilege to invite our esteemed guest of honor, Dr. Milind Vardhan, General Manager, Child Health, Uttar Pradesh. He has been very hardworking and a dedicated person and has helped a lot for developing Uttar Pradesh for us in regards to maternal and neonatal care. Um, Basically, it is when there is a public partnership with the government, it is important that we should collaborate with the public people as well, with the newborn healthcare professionals as well. Then only we can join hands with them. We are honored by your presence, sir. May I request upon to address the gathering today?
Thank you so much. I hope you can hear me. I am
Yes, sir.
busy
We can hear you.
with one more, video conference with Government of India, so I'll be very short. So first of all, it is really very, reassuring for us, and I'm very happy that uh, NNF, NI, Nutrition International, UNICEF all have joined hands with us. So this gives us assurance that we are not alone in this battle. There are a lot of people who are along with us, and I thank you all the partners who are, joined hand with us. So first of all, I'd like to begin with two, indicators which were presented in NFHS 6. Although exclusive breastfeeding, the initial early initiation of breastfeeding, it has increased from 24% to 43%, but still it is only 43%. But when we look at the percentage of institutional delivery, it is more than 86%. So when we are getting the mothers to our hospitals, it could be a private hospital, it could be a public hospital. Why cannot we initiate breastfeeding in all of them? That is one question. Second is exclusive breastfeeding. So exclusive breastfeeding for 6 months, it has dropped drastically from NFHS 5 to NFHS 6 to the extent that it was around 60% in NFHS 5 and it is only 35% now. So we need to look beyond the hospitals also. We need to, look what is happening to the mothers, to the babies when they go back to the community, when they go back to their homes from our hospitals. So very briefly, I'd like to, showcase what all government is doing to promote breastfeeding. So I'll classify the interventions into two parts. First would be facility-based interventions. So we promote breastfeeding immediately after delivery, skin-to-skin contact, kangaroo mother care, rooming in, lactational counseling before we discharge the mothers, management of breastfeeding difficulties, if there are any. Then once the baby and the mother are discharged, there is one program which is called HBNC, home-based newborn care, where Asha visits the baby for 42 days and then the program transforms into HBYC. So for 6 months, there is a regular visit of Ashas to every newborn, be it just a moment. Hmm. So, so despite the Asha visiting every newborn for 6 months, we still cannot ensure exclusive breastfeeding for 6 months for all of them. So that is one concern. We need to look at the quality of the visit that is being done. Then there are VHND days. Whenever the kid is brought to the VHND session for immunization, for vaccination, we counsel the mother for exclusive breastfeeding. Still, we cannot achieve 100% exclusive breastfeeding, and still, rather, the percentage is falling. So we need to look at that also. So these are the interventions that we are doing in facility and also in community. But all these things is only, directed towards the mothers who are coming to us. By us, we mean the government system, the National Health Mission. So I believe we are still attempting only 50% of the question paper, and we are expecting that we pass with 100% marks, which is not possible. So we need to focus on the other half, which is the private sector, or which could be organized or unorganized. But still there are, as Dr. Akash Pandit always says, that क्यों हम बात करते हैं प्राइवेट और सरकारी सिस्टम की, हैं तो वो हमारे बच्चे, हमारे प्रदेश के बच्चे. So we need to look at it through that lens. What are the factors which are, preventing the exclusivity of breastfeeding for 6 months? We need to address those factors. If there is anything that is needed from the government sides, we are open to suggestions. If there is anything that we are missing, probably sitting at the state, we cannot see what is going on the other side of the table. So if anything that is visible to the other side. If they want to point it out, we are open to that suggestion also. So these are the few things we need to look into. We have got experts and who will be talking in detail about various aspects of breastfeeding. So I'm listening to all of you, and I have another meeting which is going on. So I'd like to, end my talk here. Thank you.
Thank you, sir. Thank you very much for your valuable guidance and for highlighting the importance of coordinated efforts to improve the breastfeeding practices across UP. Our next address is from Nutritional International, an organization that has consistently worked toward improving maternal, newborn, and child nutrition. I warmly invite Mrs. Sangeeta Karmakar from Nutrition International to share her thoughts and the organization's perspective on supporting breastfeeding and maternal nutrition. We welcome you, ma'am.
Thank you, Dr. Priyanka. It is really an honor for me to talk with all you people and also listen to you, the experts here. Breastfeeding is nothing new that we all are aware of it. Since 1922, we are celebrating the week also. But the most important, the few things what we want to bring to your notice is that when we say that we are counseling, are we really counseling at any level, whether it is a facility or community? We are passing the information to them. So if we are passing the only information कि breastfeeding ऐसे करना होता है, latching positioning ऐसी होनी चाहिए, latching ऐसी करनी चाहिए. Is it sufficient to them? Because I think when we say counseling, I feel we are not actually doing the whole counseling part. We are just giving the awareness. We're just giving some information to them. What we have to look into it, if you really want to do the counseling, we have to go beyond your awareness or passing the information. We have to think about, is that the information that we have given to the pregnant lady, or you are giving to the newly mother, where the person has been able to understand it. And if she is understanding it, whether she is having some trouble into it. If she is having some problem, what is that? You have to identify it. And once the problem is identified, the problem needs to be shooted there. The person who is convincing, whether skilled at the community level, the person is there, or at the facility level, the person needs to support the lady how it can be sorted out. So we are actually, I strongly feel we have to move from the awareness part to the counseling part in the real context. Second thing I also would like to say that when we talk about family participation and talk about involving the family, are we really involving the family in a true sense? I think we should involve the family right from the beginning when she is in the ANC period. Why not start talking with her on the breastfeeding right from the beginning and in front of the mother-in-law and the husband? How it's going to benefit both mother as well as the baby. Once you are doing it, then only I think then slowly mind is make up with that. Then slowly the process can start it. Because finally what we want to say, we want to see the change in behavior is there. Unless until information is translated into the changing in the behavior, we'll still struggle on the breastfeeding part, and we don't know how many years we'll go along in the same way and where we are going to lead that. And when we say family involvement, I think when we are beyond the ANC part, when the baby is discharged from the clinic or the facility, whole family, whosoever available there, they should be involved into the counseling part. Because when we say 8 बार minimum उनको दूध पिलाना है, रात को जरूर पिलाना है, is the family supporting her into it? When she goes back, is this the process you have said it? Will be able to do it alone? Will the family is working and helping her out to do it? So ये सारी चीजें I think we need to work into that part also. And when, like just now, Dr. Milian sir said ki there is a provision for different platforms are there at the community level also. Home visits are there, VHNDs are there, mothers group meetings are there. Even ICD is having some platforms. So many platforms are there. But again, I say, whenever you use it, you need to work on the counseling part first. instead of going up to the awareness only. Second thing is involving the family at every stages. Then only I think we will be able to achieve the desired result. Thank you from my side.
Thank you, ma'am. Thank you very much for sharing the important perspective on importance of counseling and family participation. It is a need of the hour, probably. We will move to our scientific sessions now. Our first scientific session takes us through the entire breastfeeding journey, from the critical first hour after birth to exclusive breastfeeding during the first 6 months. The golden hour is not merely a symbolic phrase, it represents an important window for initiating skin to skin contact, supporting early breastfeeding, and helping establishing the maternal confidence. However, the sustaining breastfeeding for 6 months require continued counseling and support. It is my privilege to invite Dr. Ashish Prakash sir, President UP NNF, and an excellent speaker to speak on golden hour to 6 months, evidence-based breastfeeding practices. We welcome you, sir. You can share your presentation.
Thank you, Dr. Priyanka, and thank you for inviting to this session. I am cognizant of the responsibility placed on the shoulders of UP NNF in this regard as I begin the talk and go through the session. At the outset, I want to say that this talk, what it is not about. It is certainly not about the breast milk being very natural and a beautiful phenomena of breastfeeding, because we all are aware of it. And I will not say that mothers should be made to push harder, and nor am I going to convince the room here to advise about breastfeeding. We all know this. This is a clinical talk, and we are going to discuss certain set time-sensitive procedures, which actually, if followed, make, and if not followed, make or mar the whole process of breastfeeding. And the talk will be based on the recommendations from WHO, UNICEF, evidence-based randomized controlled trials, Cochrane reviews, and our own family health surveys. The theme this time is strengthen what works, and I have taken it literally. So through the session, I will bring forth certain things which really work. And my request to all participants would be to go back and implement these things in their units, which really work. So let me start sharing the screen. So as I said, that we will be talking about, as Priyanka said, from golden hour to 6 months, evidence-based breastfeeding practices. Now, here, let me first give you 3 numbers. First number is 823,000. These are the child deaths preventable every year with near universal breastfeeding. And and this means that about 13% of all deaths under 2 years of age can be prevented by exclusive breastfeeding. Now, this intervention alone, this outcome, is much more than many other interventions that we do in child health. Next number is 20,000. Now, this number is maternal deaths prevented from breast cancer every year by exclusive breastfeeding. Third number is 300 billion US dollars. This is the saving of almost per year of this many dollars by exclusive breastfeeding, because this prevents the loss of cognitive potential. Globally, currently we know that 48% of the infants under 6 months are being exclusively breastfed. And the World Health Assembly in 2025 raised the global target to at least 60% by 2030. So these are the numbers. These effects are there for everyone to see. But the world is aware, but the world doesn't seem to be doing anything about it, or not much about it. Now, Milind sir referred to the NFHS 6. I do not have the access to the full report, but the salient points I will elaborate upon. We have made certain improvements. The initiation of breastfeeding within first hour has improved above the previous NFHS 5. His figures were a little different, but it has significantly improved. Similarly, introduction of complementary food at 6 to 8 months has improved. More babies are being delivered in the institutions now. Almost 9 out of 10. He was saying 8, whatever the right figure is, but it has improved, which means the babies are reaching our facilities. Probably our practices don't reach them. Now, the compliment for this improvement certainly goes to this group in the room today. But a shocker is there. What's sir referred to? That exclusive breastfeeding under 6 months has come down significantly. So this is where our focus should be. There is data to show that 95.6% of Indian infants under 6 months receive some breast milk. So the mother is giving breast milk. Where is the problem? The problem is not that babies are not being breastfed, the mothers are not breastfeeding. The problem is with timing and exclusivity, which means, is it being started at the right time, and is exclusive breastfeeding being practiced? So these two things, ensuring that these two things happen, is in the hands of us sitting in the room today. My talk will move in this direction, opening 4 windows to you, which actually is a continuum. First, the golden hour, which everyone referred to before me. Then first few days immediately after birth. Then we'll talk about the vulnerable newborn, and then over to the 6 months. Each section closes with one thing that you can change in your unit before the end of this week. So the golden hour first. What we do and what we fail to do in this hour actually predicts the next 6 months. So we should be aware of this. Now, this slide, what I'm showing you, I am willing to confess and accept that I was not aware of this behavior, which is certain innate behavioral sequential steps that a baby shows if you place him immediately after birth in skin-to-skin contact with his mother on the mother's chest. These things, it is a treat to watch. Lately, ever since I have been observing, it is a real treat. That the baby first cries, then there is a phase of relaxation, and then there is awakening. Then he shows activity and maybe rests again. And then he starts crawling to the breast, gets to familiarize, and this is where the whole magic begins. He is nuzzling, he is groping for the nipple, and he is licking, and then he starts suckling, has a good feed, and goes off to sleep. These behaviors are innate to every newborn and are sequential. The rest may occur at any point, that's different. But if you interrupt this sequence by the things that you would do, like weighing, bathing, giving an injection, or simply to observe, then this sequence doesn't pause. It actually stops and it has to reset. And when it starts again, it does not complete at all. And mind you, while the baby is doing this, skin-to-skin contact is doing heavy clinical work. Thermoregulation, for which you may have so many equipments. Glycemic stability, cardiorespiratory stabilization of the newborn, colonization with the mother's flora, the baby is getting colonized, and oxytocin release for uterine contractions. Imagine all this at no cost, without any equipment, simultaneously happening. Now, people would argue that, but where is the evidence? Now, this is the evidence. A 2025 Cochrane review, which was updated in October last year, it showed that babies who were exclusively breastfed and they from after discharge up till the end of 1 month, if the babies were in skin-to-skin contact, starting within the first golden hour, they were exclusively breastfeeding at 1 month. And if the same babies who were given skin-to-skin contact in first hours, they had almost 30% more chance of continuing exclusive breastfeeding at 6 months. And what else is happening? The baby's physiological stability is happening side by side. Blood glucose is higher by 10.5 milligrams per deciliter. Imagine how many IV drips you would prevent by this. Auxiliary temperatures are higher by 0.28 degrees centigrade. Babies have better cardiorespiratory stabilization. What was not proven was that maternal blood Am I audible?
Yes, sir, you're audible.
Okay. But what this study could not prove conclusively was decrease in the maternal blood loss or third stage duration. Now, all this evidence is based on 69 randomized trials, 7,290 mother-infant pairs, and infants were more than 34 weeks. And mind you, both vaginal and cesarean section births were included. I'll come to this cesarean business later. And the reviewers' conclusion was that because WHO and UNICEF already recommend immediate uninterrupted skin-to-skin as standard of care, randomizing newborns to separation from their mothers is no longer justifiable. So now we should understand that giving this early skin-to-skin contact for the baby on mother's chest is not sort of optional today. It is the standard of care which we have to follow. There is a caveat, however, with this Cochrane review that low-income group countries were not actually included in this. So we have talked about the benefit of breastfeeding outcomes by this early putting the baby on mother's chest. But now let us look at the numbers. Now, this timing, if we compare the babies who were first breastfed within 1 hour of birth versus babies who received breastfeeding at 2 to 23 hours, these babies who were delayed by even 1 hour for their first feed had 33% higher risk of neonatal death. And if the breastfeeding was delayed by more than 24 hours, the risk of neonatal death actually increased twofold. Now, this is pooled evidence from 5 studies. This association persisted among infants who were exclusively breastfed, even after this intervention was over. And in a pooled NeoBeta analysis, the survivor advantage of initiation within the first hour remained after adjusting for feeding patterns even at 1 and 3 months. So it is not something which is optional that I will put the baby to breast once the round is over, once the sister has taken the over. No. And imagine why this urgency? Because what are you preventing? What are you obstructing by delaying the feed? You are obstructing the ingestion of colostrum, which has secretory IgA, lactoferrin, leukocytes, oligosaccharides, and growth factor. These, if delivered before any pathogen colonizes the gut, logic would say, would translate into better survival. So this is the golden hour protocol. I think all of you can take a picture of this and put it up on your labor room walls today if you don't already have this. So the do's are 6 in this order. Delay cord clamping with the baby already on the mother. Dry thoroughly. Leave the vernix in place. Cover the head. Baby prone and skin to skin on mother's bare chest. Cover both with a warm blanket. Leave them uninterrupted for at least 1 hour or until first feed is complete. But do observe continuously for color, breathing, temperature, and a visible unobstructed airway. Defer weighing giving of vitamin K, vaccines, eye care, and the full examination until after the first feed. And the do nots. Do not give any prelacteal feed of any kind. Do not routinely do the oropharyngeal suction in a vigorous baby. Do not separate a stable baby for observation in inverted commas. Do not give bottles, teats, and pacifiers. Do not bathe before 24 hours of age. And do not weigh before the first feed. Now, this is where issue becomes a bit ticklish for some. But my take is, if you delay the weighing by 90 minutes, is the weight going to change? No. And we all know, in a stable baby, there is no intervention in first 1 hour which requires or which is based on the weight of the baby. And if at all, in the first hour, some interruption has been done for a true clinical reason, restart skin to skin the moment the reason ends. Now, a word on cesarean section. There is a talk on this, but this is not an exception to the golden rule, and it has been found the benefits accrued by early skin to skin contact after cesarean is same. Now, the problem is one of the most important reasons for this interruption and losing of this benefit of first golden hour is a cesarean section. In our country, studies have shown this. And with progressive increase in cesarean section deliveries, our focus, if only on vaginal deliveries is there, we are going to lose a whole lot of babies. Now, from golden hour, moving to first few days after delivery to discharge, lactation is established or lost, believe me, in the first 72 hours. So we have to focus on these. Now, what are the 10 steps to successful breastfeeding? These are the revised criteria of 2018. Now, very importantly, 1A, which used to be an ethical sort of footnote, has become now essential, and the compliance with this is being assessed for healthcare facilities. This is, they have to comply fully with the International Code of Marketing of Breast Milk Substitutes. I will not read the whole list. Then again, there should be a written infant feeding policy, and there should be ongoing monitoring that the staff is sufficiently trained, has the competence and the skills. Amongst the clinical practices, I will go over the ones which get missed out. Number 4, to facilitate immediate uninterrupted skin to skin contact that I just mentioned and support mothers' initiation to breastfeeding. Number 6, give breastfed newborns no food or fluids other than breast milk unless medically indicated. Then number 7, enable mothers and infants to remain together and to practice rooming in 24 hours a day. They should be together. And counsel mothers on the use of risks of feeding bottles, teats, and pacifiers. These 10 commandments, they are being delivered through the Mother's Absolute Affection Initiative program, and of course, the Baby Friendly Hospital Initiative accreditation. And the facilities are being monitored for compliances once they are recognized. Is the baby getting enough? The answer to this question is the biggest reason for failure of exclusive breastfeeding. The answer is either reassurance, which invariably fails. The other answer is a bottle, which usually wins and always does well, apparently. So what should we do? We should answer with science. Science with all the pun intended. Science as SIGNS, and science, which is Vigyan. So what signs should we be watching for? Check the feeding. That 8 to 10 feeds should be given in 24 hours in early weeks and driven by baby's cues. Babies should be passing 6 or more heavy wet nappies in a day from day 4 to 5. Urine should be pale and odorless. Stools yellow and seedy by day 4 to 5, at least 3 times a day in early weeks. Weight, very important. Loss usually within about 7% of birth weight. Birth weight regained by 10 to 14 days and then a steady gain. Behavior, very important to be observed. Audible, swallowing during feeds, and the baby should settle afterwards. But there are certain red flag signs also, which should be weight loss more than 10%, fewer than 4 wet nappies after day 4, Meconium still being passed on day 5, a relative red flag. A sleepy baby who does not wake up to feed or feeds under 5 minutes. Jaundice accompanied by poor intake. Mother reports pain throughout the feed, not only to latch. The threshold in common clinical use, assess every every infant individually, and very importantly for all healthcare workers, watch a whole feed before you prescribe anything, before you decide that this is a problem and he needs some supplement. Coming to supplements, the next window. When is it actually indicated? There are well-defined guidelines. WHO says that galactosemia, maple syrup urine disease, phenylketonuria, certainly they need specialized formula. Then coming to next category, breast milk still the best, but may need some extra briefly. This is group less than 1500 grams at birth, less than 32 weeks at birth, and babies at risk for hypoglycemia, preemies, small for gestation age, having suffered hypoxic ischemic stress, ill, or infants of a diabetic mother. But even in these babies, first a trial of optimal breastfeeding or breast milk feeding should be given, and only a failure to maintain euglycemia should make one think of giving a supplement. Certainly, supplementation is not indicated for physiological weight loss within normal limit, day 2 clustering of feed or night waking, which mothers may complain, maternal fatigue or undue family pressure, and the common take of not enough milk without feeding assessment, as I mentioned. Uncomplicated physiological jaundice, certainly not, if at all. It requires that you encourage breastfeeding. Convenience of the ward routine, certainly not. And if supplementation needed, it is in this order: mother's own expressed milk, pasteurized donor human milk, only then formula. And certainly not a bottle, cup, palladi, or spoon can be used. And if at all it is done, make it a policy today onwards in your units that the medical indication for such a supplementation should be written in the notes. Now, a quick word about the vulnerable newborns, the preemies, the low birth weight, and the sick infants. Actually, these are the babies who need the mother's milk the most. And actually, in practice, these are the ones who invariably get separated from their mother. So, preemies and low birth weight, the WHO thankfully has moved the clock to start from 0. It was found that if the KMC was started immediately versus conventional care, this immediate KMC reduced the mortality by 12% as compared to 15.7%. And the trial had to be actually stopped early by data and safety monitoring because of the advantages being accrued. So start kangaroo mother care immediately after birth without an initial period in incubator for all preemies and low birth weight babies, except those who are unable to breathe spontaneously after resuscitation or are in a shock or requiring mechanical ventilation. Of course, feed mother's own milk to all preterms or low birth weight babies, including those under 32 weeks or under 1.5 kgs. Colostrum matters the most. I alluded to this earlier. And when mother's milk is not available, donor human milk is the next option. And feed from the first day, put the infant to breast as soon as possible. Now moving to the next window, to the 6 months. Sustaining exclusive breastfeeding after discharge, as Dr. Milind mentioned, so many things are being done to ensure this sustenance. But let me say, we in a hospital open the doors, and it is the community decides whether it stays open or closes on our faces. And this is where the role of ANMs, ASHA workers, home visits come in. So let us define what exclusive breastfeeding is that we keep on talking about, because the precise words matter. Exclusive breastfeeding means only breast milk, including expressed or donor human milk, no other food or liquid, not even water. ORS, some drops and syrups of vitamins and minerals and medicines are permitted. WHO, UNICEF, and all bodies recommend that 6 months of exclusive breastfeeding should be there. then complementary foods should be introduced with continued breastfeeding for 2 years or even beyond. Now, what does the 6 months of exclusive breastfeeding buys for us and the baby? On the infection front, in low and middle income settings, about half of all diarrheal episodes and 1/3 of respiratory infections can be avoided. In high income group countries, there is 1/3 lower risk of sudden infant death. Long-term benefits are in the health of the baby. This is associated with 30% lower risk of overweight and obesity, 35% lower risk of type 2 diabetes, and 19% lower risk of childhood leukemia. And the gains for mother are, of course, there. There is a lower risk of breast and ovarian cancer and type 2 diabetes, delayed return of fertility, and less postpartum blood loss. I mentioned these figures earlier. Globally, 48% under 6 months are exclusively breastfed, and the target is 2030, 60%. And as I said, exclusively breastfed babies, the percentage in the latest health survey has come down from the previous years. We have to really work towards achieving this target, or maybe better, because we know traditionally breastfeeding has been better in low income group countries compared to high income group countries. So whatever may be the international target, we should do better. Now, this exclusive breastfeeding, it doesn't suddenly deteriorate at 6 months. There is a constant leak month by month. Let us look at some of these figures. These are from NFHS 5 and 4 because 6 was not available as yet. Out of all the babies who start breastfeeding at birth, every month there is attrition. Look at this. At 2 months, only 70.4 are doing it. By 4 months, 61.5% are doing it. And the drop is more precipitous between 4 to 6 months. By 6 months, only 43% are doing it. Now, which are the babies on whom to focus, who are most likely to lose it? The babies where breastfeeding started after the first hour, babies under 2 kgs of weight, mothers under 20 years of age. And what actually can help with continuation? Repeated, skilled, face-to-face support, both antenatal and postnatal, not a single leaflet, not one instruction as Madam Kamakar mentioned. It is ongoing. A postnatal contact within first week when most mothers decide whether to continue or not to continue. Community and peer counseling. Again, the importance of counseling, not sort of patronizing and giving them some information through ASHA and ANMs under the MAA program. Facilities that actually implement the 10 steps will go a long way in doing this. In the formal sector, maternity benefits are there, 26 weeks of paid leave. There is a creche requirement for establishment with 50 or more employees. But there is a profound problem in the informal sector where many mothers are working. Situations where even health personnel stop breastfeeding unnecessarily. HIV mother. We all know that mothers on retroviral therapy and should be exclusively breastfeeding for 6 months, add complementary food, and continue breastfeeding for at least 12 months, if not 24 months. Maternal medication. Most drugs are compatible with breastfeeding. And if at all in doubt, check a lactation-specific source before stopping. And you can avoid and change to safer alternatives where they exist in terms of need for psychotropics, anti-epileptics, opioids, and topical iodine cytotoxic chemotherapy. Jaundice, oft-quoted reason. Jaundice from suboptimal intake. In fact, the whole definition I came to know has changed. That breast milk jaundice now has to be called suboptimal milk intake jaundice, not really breast milk jaundice. It has to be treated by feeding more, not less. And phototherapy certainly is not a reason to interrupt breastfeeding. Feeding can be done during the breaks and therapy. Risk of hypoglycemia. As I mentioned, that risk is not enough to stop. You first give a fair trial, and if not working, only then think. And breastfeeding should continue in the setting of maternal hepatitis B, hepatitis C, mastitis, abscess, and even in tuberculosis as per the national guidelines. In the end, I would say that true contraindications are rare. Before you stop to feed, you do stop and see what the evidence says and see to it, is it really necessary? Now, 6 months is the big transition, but certainly it is not the end point of breastfeeding. What the guidelines say that introduce complementary food at 6 months or 180 completed days while continuing to breastfeed, and continue breastfeeding, which can be done up to 2 years of age or even beyond, because breast milk contains important source of energy, protein, and micronutrients, which are helpful even in the second year. And it is very important to continue breastfeeding during the illness of a child. And certainly, immediately after illness, more the breastfeeding, the better is the recovery. And these gaps in our own NFHS survey, which actually covered almost 700,000 households and probably 751 districts, these are some of the gains that the timely complementary food at 6 to 8 months, this percentage has increased, and the 6 to 23 months children receiving adequate diet, this has also increased from 11 to 15%. But let us not celebrate the gains. We have to focus on the decline in the exclusive breastfeeding at 6 months. So the counseling points that one should remember, that 6 months means completed 180 days, not once the baby is just past 5 months. Add food to breastfeeding, do not substitute it. And as I said, breastfeed during the illness, and start with thick, energy dense food, not thin gruels. So after the talk, the amount that I have talked up till now, if we sit back and think, everyone who's participating, what changes would you do starting from Monday next week? For the nurses and midwives, protect the first hour, put the baby back to the chest after any interruption, teach attachments with a hands-off approach. Show it on your own, not on the mother's body, because mother has to go and repeat it alone. So she should be doing it, you should be demonstrating. Record the time of the first feed in every delivery note. Only cup, paladi, never a bottle for any expressed milk. For the pediatrician friends here, make immediate KMC and the default order for every preemie and low birth weight baby. Write into the ward policy, no pre-lacteal feeds and no formula without a documented indication. Add expression within the first hours to NICU admission order set. Audit early initiation and exclusivity at discharge every month. For the trainees, learn to assess complete feed before you ever prescribe a formula. Learn hand expression. You should also know this art. Ask every single time, why is this baby separate from his mother? And know the acceptable medical reasons list by heart. So for the units, pick up one measurable indicator, the percentage of babies breastfed within the first hour or exclusively breastfed babies at discharge. Put it on a notice board and review it monthly. Believe me, what is not measured does not improve. That is the dictum. So 5 takeaways after this talk. The first hour is a time-sensitive clinical intervention. Treat it the way you treat the first breath. Skin to skin after every birth, including cesarean, is standard of care. It is not an optional comfort measure. For preterms and low birth weight babies, KMC and mother's own milk begin immediately, not after stabilization. Supplement only for a documented medical indication, and then also it is mother's milk, donor's milk, and formula in that order, and by a cup or a spoon. Breastfeeding fails when the system fails, not because the mother fails. So fix the system. Review your policies. Review the staff skills. There should be ongoing updation of the skills and measurement of the measurables, and of course the compliance to the IMS code. So the slogan for the breastfeeding week, breastfeeding for a sustainable start in life, strengthen what works. I think I have mentioned a few things which work. Now, strengthening in your own units, going back from today's talk, is my earnest request to all the participants here. Thank you so much.
Thank you, sir. Thank you for taking us through the evidence as well as its practical application. Your message clearly reinforces of early initiation and continued support must go hand in hand. Now, I invite Dr. Ms. Neha Maheshwari, lactational consultant, to demonstrate and discuss correct positioning and latch, as many of the problems with breastfeeding like maternal pain, nipple trauma, apparently inadequate milk transfer, they begin just with as simple as fundamental positioning and attachment. So, Ms. Neha, the platform is yours.
Thank you so much, Dr. Priyanka. Thank you so much, Dr. Prakash. So when you talked about one half of the mothers not being able to breastfeed in the first hour, I was that one half of those mothers. So that's why we are here today, to understand what does an effective latch look like. We have stressed enough about the golden hour and the importance of uninterrupted skin to skin time. But I also want us, all of this group, to understand what an effective latch looks like, why is it important, why is it a big contributor to our declining exclusive breastfeeding rates. But before I begin, a little bit about me. So I've been a public health professional working with in the MNCH initiatives of Government of Bihar and Government of UP a couple of years ago, before I became a mother. And I was involved in the deployment of digital health systems for the Government of Bihar, along with Pramal Foundation. I moved from community-based health interventions just to understand what happens on the other side of the table. Just like Dr. Vardhan said, कि 50% of the question paper तो हमें पता ही नहीं है, कि problems क्या हैं वो हमको पता ही नहीं है. So to understand that 50% of that question paper is why I moved to the other side of the table. And I currently work with mothers in the hospital, at their home, working every day with preemie mothers, with mothers of sick and extremely low birth weight newborns, and also working with parents who are now transitioning back to work. And these parents are not only those who are in the corporate sector, but also our nursing staff, our staff that is our GDA staff, right? So just making sure that the unorganized sector also benefits as much as the organized sector does. So with that in mind, let's begin the art and science of latching. So we talked about early initiation of breastfeeding. Two very important things that work with breastfeeding are effective and frequent feeding that drive milk supply. I hope all of you can see the slide. Give me a thumbs up. Give me a show of hands. Give me a quick.
They're visible.
Yep. Thanks, Dr. Priyanka. Thank you. So I'm here to talk about effective feeding at the breast, which will be followed by frequent feeding at the breast. But today, in this session, we'll only talk about effective feeding, right? Let's look at what do we say about breastfeeding, right? It's intuitive. It's should be done by every mother. अभी हो ही जाता है. Every mother would know. हमने भी किया था. हमारे ज़माने में तो कोई नहीं सिखाता था. अरे ये तो कराना ही नहीं चाहती हैं. And the biggest myth of all that I keep hearing all the time, abhi doodh hi nahi aaya hai, right? So we keep hearing from mothers, from us as healthcare professionals, that abhi doodh hi nahi aaya hai. Although all of us know that breastfeeding the breast milk production starts right in pregnancy, right? The colostrum production starts right in pregnancy in these tiny alveolar structures. And the mother is already filled with colostrum by the end of the third trimester. But we keep hearing that abhi doodh nahi aaya hai, right? And as a new mother, I was also struggling. I did not get that golden hour. I struggled big time in the initial first 15 days with breastfeeding, with establishing a latch, and until I figured it out, right? So here, the key point that I keep iterating to everybody, each healthcare professional, is that breastfeeding is a learned skill. It's intuitive, but after a certain point, because there are so many interventions that happen during birth, after birth, during their time at the hospital, that it automatically becomes a left brain activity rather than a right brain activity. So breastfeeding is a learned skill, and we'll learn a little bit about breastfeeding today so that we are able to help mothers in our hospitals and our nursing homes as a part of the government initiatives. And Asha Didis do a tremendous job during their HBNC initiatives, which I have been a part of day in and day out. And the kind of support that is provided by the government as a part of the follow-up activities, I wish we could do even 10% of that in the private healthcare setup. Right? So what's a deep latch today? We'll look at how to achieve a deep latch, why deep latch is important, and what makes it difficult, right? So what makes a deep latch difficult for the mother to achieve or for the baby to achieve, and the impact of achieving a deep latch early on, learning the science of latching early on, right? Give me a thumbs up if you're here until here, because now we have an exercise coming up. I know it's a post-lunch session, so it will not be a very, very tedious exercise. It will be something that you can do on your chair. Can we do an exercise? Give me a thumbs up, everybody. All right, I got 1, 2 thumbs up. Only for Dr. Priyanka. Okay, all right. So I want all of us to take our tongue to the top of our mouth. What do we feel? We feel a hard surface, right? We feel a hard surface. Now take the tongue to a little back. What do we feel? A softer surface. So that's your soft palate and that's your hard palate, right? So when we are talking about a deep latch, we are also telling the mothers that, hey, your nipple and the areolar region should go deep into the baby's mouth, touching the juncture of the hard and the soft palate. जहां पे हार्ड और सॉफ्ट पैलेट मिलते हैं वहां तक आपका निपल और एरियोलर रीजन जाना चाहिए. So that is how they're able to relate that, okay, I should be latching deep enough, right? So remember, the nipple and the areolar region should be deep into the baby's mouth. When the nipple touches the juncture of the soft and the hard palate, it triggers the sucking reflex, which is also very innate to all newborns, but it triggers the sucking reflex and it makes the latching easier for them, right? Another exercise that I want you to do with me is, okay, let's take a glass of water. Everybody has a glass of water along with them, a bottle of water, a glass of water. Okay, this group needs to be a little interactive. All right, I'll go ahead. So let's try to take a sip of water by keeping our head down, right? Head down. Now let's extend the neck a little bit and take a sip of water. Which one was easier? Which one was easier? The one where your neck was extended, right? And we all know our infants have a very wobbly neck, right? Our infants have a very wobbly neck. So when they come to the mother, if their necks are wobbly, if they're not supported well, what will happen? They will not be able to feed properly, right? So that is the key role of positioning a mother well. And that is what I'll demonstrate in the next few minutes, right? So let's look at what does a deep latch contains, right? What are the two very important things that a deep latch should have? So the right position of the mother, we'll talk about it in a bit, and also the suction and the compression from the baby's mouth, right? So when the baby sucks on the nipple and the areolar region of the mother, what happens is they compress the nipple and the areolar region using their cheeks, and they're also moving their tongue in a vigorous wave-like fashion, right? This fashion. So this gives them a negative pressure area. There's a positive pressure area on the breast, and the milk starts flowing down. So the milk starts flowing down from the alveoli to the milk ducts and to the nipple, right? So this is the exact same thing that we'll try to see, and what actually acts as a challenge. So that also, we'll also try to address that. So understood two things: right position, suction and compression, right? And we'll keep coming back to this slide. So I want this to be ingrained in all of our minds. Right position, suction and compression. That leads to effective milk transfer. All right. So now let's look at, I want all eyes on the screen. That's why there's very minimal on the slide, very minimal text on the slide. So whenever we take our babies, right, how are they wrapped? They're tightly swaddled, wrapped and everything, right? the first thing that I want you to do is open all of these swaddles. Open all of these swaddles. Open the swaddle and position the mother well, right? So whenever we talk about positioning, I talk about the 3 B's. So what are the 3 B's? The first is the mother, right? So the back of the mother. So get the mother up. If they have delivered via C-section, then they can still feed in a sideline position, and we'll talk about the sideline position in a bit. So the first day they are in a sideline position, and then following days they are in a laid back position, and they are supported with the back of the mother. But consider that a mother is feeding at her home, right? What do you need to teach her? You support your back well. So you have a pillow at the back of your back. If you're feeding on a chair, it's even better. You can put a footstool in front of you, right? Take the baby on another pillow. It can be a feeding pillow. It can be any other pillow. So the back of the mother is well supported. That's your first B, right? Back of the mother supported. Let's look at how do we support the baby, right? So the baby needs the support running across the spine up until their buttocks and their legs. So back, 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 right? So we'll use the forearm, and this is just one position that we are talking about. There are multiple positions that we can do with breastfeeding. This is just one cross cradle hold that we are doing today, right? And the most common one that we have seen in our homes, in movies, everywhere else, right? So we take the back of our hand, the forearm, and then we run it across the spine of the baby, right? Look how nicely the baby is supported, and the nape of the neck is supported with the C of my hand, right? It's not the head. I'm not compressing against the head. I'm just supporting at the nape of the neck, right? So the nape of the neck is supported, and my hand is resting upon its spine so that it can still be supported at the back, and the legs are also supported. Notice whenever we are feeding, right? Whenever we are eating our dal chawal, whenever we are eating our khichdi, whenever we are eating roti sabzi, हम डाइनिंग टेबल पे जब भी खाते हैं या हम अभी स्टडी टेबल पे बैठे हैं तो हमारे पैर कहाँ पे हैं? Our legs are always searching for support, right? Even if you notice right now, our legs are searching for support. कहीं पे तो फ्लोर आ जाए, right? That's exactly what we do. Supporting the floor, the legs of the baby up until the last corner, right? So a feeding pillow works very well, but otherwise also normal pillows can also work, right? Once the baby is well supported, and I'll stand up for this. So the second B is supported, right? Done. Back of the mother, baby well supported, done and dusted. Now we'll support the third B. What's the third B here? What are we here to talk about? Breastfeeding, right? Now I want you to imagine eating a big burger. Can you imagine eating a big burger bun? I know it's lunchtime. I know maybe some of us have missed the lunch and the picture is not doing a great job. How do we eat a burger? We always compress it, take a big mouthful, right? And that's exactly what we have to tell our mothers. I want you to eat a burger. They would have not eaten a burger for a very long time considering they were pregnant, but just ask them to imagine. Imagine eating a big burger. That is what you have to teach your child. So sandwiching the breast in such a manner that the nipple and the areolar region go deep into the baby's mouth. I'll show it on myself and then we can go ahead. Right? Yeah. So what do? We support the baby. Now stand up for this. I hope everybody can see me. So we get the baby nose to nipple. Now this is one of the common things that you will keep hearing about in breastfeeding, right? Nose to nipple, chin first, all of it. I'm just repeating it for you. Nose to nipple, chin first. So the baby's chin is touching the areolar region first, chin first. The baby will open a mouth wide like this. We are not shoving off the nipple into the baby's mouth. We are just enabling them to feed better, right? So what we'll do, we'll just attach the baby chin first, and then we will not bend. The mother will not bend. The baby will come to the breast, right? So the mother does not bend. The baby comes to the breast, and then they start feeding. So the breast can be supported in a C hold. It can be supported in a thumbs up mode. So everybody knows thumbs up. Somehow everybody knows these brands. So I just tell them, okay, you can go do a thumbs up on the left hand side of the breast. If they have smaller breasts, just a little bit of a finger also helps. right? So based on the breast anatomy, we try to support mothers as per their anatomy and the baby's anatomy. So that is how we support the mothers. Now, this is one position, right? We understood 3 Bs: back, breast, baby, right? Make use of gravity, right? If you have a mother who is feeding on deep in a laid back position, even better. This is one of the most natural ways to feed a baby. This is called biological nursing, right? One of the most natural ways, one of the most easiest ways, because gravity helps you in maintaining the position, right? Baby's legs and hips are still supported, the baby is still tummy to tummy, पूरा करवट से लिटाया हुआ है बच्चे को, तो मदर की जो पोजीशन है हम बस वही चेंज करते रहते हैं, जो बेबी की पोजीशन है वो अभी भी वही है, अभी भी हम लोग टमी टू टमी करवट से लेटा के एक हाथ ऊपर एक हाथ नीचे, मिटन्स नहीं पहनाए हैं. वी वांट अ लॉट ऑफ सेंसरी स्टिमुलेशन and hands off the dinner plate. So I want all the hands, whenever we are supporting the mothers, somehow they have been told to do a kenchi, right? Kenchi bana ke pila lijiye. And this is something that dadis and nannies will always tell them. But I want hands off the dinner plate. So this is the dinner plate. This is the dal chawal plate of the baby. We want to put our hands and fingers away from the areola so that they can take a deep bite full of the lower part of the areola, if not even the upper part. So when you attach the baby chin first, right, what happens? The lower part of the areola goes deep into the mouth, and that is exactly what we want. The upper part of the areola jaye nahi jaye koi baat nahi, that's okay, right? Lower part should go as deep into the mouth of the baby as much as possible. So we understood 3 Bs: gravity, legs and hips supported, sensory stimulation, hands off the dinner plate, and skin to skin. If mothers can feed skin to skin in your facility, nothing like it. Do not complicate it using fancy gowns. Tell them to feed using open shirts. That'll be even better, so that the babies can be given at least 140 minutes of breast time in the first few days, right? Every day, at least they're getting more and more breast time, right? If they don't get breast time, then how will they breastfeed? So just a quick revision: tummy to tummy, nose to nipple, chin first, straight line from the baby's ears. So ये तो किसी को समझ आता नहीं है जनरली, वो हम लोग बोलते हैं करवट से आप लेटा लीजिए. जनरली हम लोग यहाँ पे बोलेंगे अगर करवट से लेटाएंगे तो सबको समझ में आता है. So straight line from ears, shoulders, neck, spine, and everything supported. अगर बच्चों को लगेगा कि हम गिर रहे हैं, wobbly हैं, they will not feed. So imagine if you have to choose between feeding and saving your life, what will you do? You will always feed. Oh no, हम लोग adults हैं, हम लोग फिर भी खाने के बारे में सोचेंगे. Babies will still try to save their lives. तो जितना अच्छा support अगर उनके पैरों पे रहेगा उतना ही अच्छा रहेगा. And the more supported they feel, the better they will feel, right? Now, what are the signs of a good latch? Gulping sounds. Dr. Prakash talked about audible sounds in his presentation, right? Audible sounds is something that the healthcare professional who is checking the latch can actually ascertain कि gulping sounds आ रहे हैं कि नहीं आ रहे हैं. Mother को हम लोग generally यही बताते हैं कि you can check for sucks and swallows, right? Whenever you do a suck, you can see the baby is pausing for swallow, right? So that's the pause that you're looking at. Slowly, when the babies start growing older, when the breasts start becoming fuller, the audible sounds are even clearer. But this is something that day 1, 2, 3 pe, you can start telling your mothers that if you do like a small suck, and the baby is sucking, suck, and then swallowing, that means the baby is getting milk, right? Because they'll always have that question, दूध आ रहा है कि नहीं आ रहा है, दिख रहा है कि नहीं दिख रहा है. दिखना बहुत जरूरी है. Somehow our generation just needs to see things to believe things. So that is something that I tell our moms in the hospital, that if the baby is pausing for swallows, they are getting enough milk. And of course, we keep validating with the P count and the weight gain and the parameters that Dr. Prakash talked about. Jaw working. So the jaw should work. The cheeks should not be dimpled. There should be no pain during the feeding. A discomfort will be there, but the pain, the latch should not. If the nipple keeps rubbing against the hard palate, then the pain will continue. And that is why you have soreness in the nipples. That is why you have nipples being bled, being cut, because the nipple just keeps rubbing against the baby's mouth and the latch is not deep. A deep latch is essential for milk transfer. If the nipple is coming out pichka hua, lipstick shaped, right? Pichka hua nipple, milk transfer, nope. Right? So all of these are signs of a shallow latch, which is ineffective milk transfer. The baby is just coming onto the nipple करके चले जा रहे हैं. So that is something that we don't want. We want our babies to have milk nicely at the breast and then go off to sleep, right? Large part of the areola should be inside the mouth. There should be no clicking sound. If there is clicking sound, that means somewhere the latch is becoming shallow, the pressure, the suction is breaking, right? So no clicking sounds. And if they're just sucking, so generally when the babies come to breastfeed, right, what they will do, they will suckle a lot of times to initiate let down. Now, what is let down? The milk starts flowing from these alveoli to the nipple, right? This is let down. The oxytocin starts working and nipple from the alveolar region, they start coming towards the nipple, right? So this happens and then they go to suck, swallow, suck, swallow, suck, suck, swallow, suck, suck, swallow cycles, right? Their cycles of sucks are shorter and swallows are a little paused. Now, having said that, if you see a baby who is consistently sucking throughout the feed, right? Not only after initiating leg down, but the sucks are like, okay, suck, 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 and then a swallow happens. Now, why is that happen? क्योंकि घूंट भरने में time लग रहा है. So they are not getting a big mouthful of the milk to be able to gulp it down. So that means we need to bump up the mother's supply, right? That is where our role as lactation counselors come in, as healthcare professionals come in to guide them better to be able to latch deeper and also simultaneously bump up their supply, right? So this was one position that I demonstrated on myself, cradle, cross cradle, a mix of both. And another hold that works beautifully with cesarean sections, right? And cesarean sections are rising, number of institutional births are rising, cesarean sections are rising. Football hold works very well. The same position, baby's tummy to tummy, chin first, everything remains the same. Mother has taken the baby differently, that's all. Supported on a pillow. So we are now taking the baby, just Football World Cup just went by, right? So now we are just taking the baby in like a football, like how football players get the footballs in the playground, right? In the football ground. We are just supporting the babies in another position so that the scar is not paining for them, right? So this works beautifully if the baby is not latching, with larger breasts, with flat nipples. So and it works beautifully when there are oral restrictions. A lot of times when nothing else is working, football works magically, right? So just keep it in your kitty. If one hold does not work, try another. Some hold will definitely work. I'm not able to see the questions. If there are any in the chat window, I'll pause for questions at the end of the session. Right now, somehow I'm not able to see the chat, but I'll just pause at the end, right? So keep dropping in your chat, keep dropping in your questions. If there are any, I'll answer all of them at the end of the session. Another hold that works beautifully for sideline day for cesareans, and I'm sure Dr. Agarwal will talk about it in detail in the next session, but sideline works beautifully on day 1 and 2 of cesarean sections when the mother is recovering from a major surgery. Works beautifully. Just that mental stigma of the mother is resting. Attendants हमेशा बोल देते हैं, अरे नहीं मदर को परेशान मत करिए, अरे मदर को परेशान नहीं करिए. हम बोल देते हैं नहीं, हम परेशान नहीं करेंगे, बस वो लेटी रहें, हम बच्चे को पिला के निकल जाएंगे. तो just that kind of comfort, if you give them, and training to the staff, because sideline feeds on day 1 and 2, when the mother is a primary especially, and the mother is recovering, they have to be monitored feeds. So with sideline, there is also a big caution that the healthcare staff has to be trained immaculately well to be able to conduct a sideline feed. So how to support the neck of the baby. There is no respiratory distress. There is no, the baby's neck is not getting compressed. It's a safe sleep position and all of that, right? So, and the birth happens. So sideline feed is always a monitored feed, especially when the mother is recovering. So this becomes a good catch for all of those exceptions that have been thrown at you in the day 1 and 2, where attendants are saying ki nahi aap mat karaiye, mother ko pareshan mat kariye, which is true. Mother is recovering and nobody wants to disturb a patient, right? But we just tell them we will not disturb. This is a sideline feed. Even if you don't turn, I will put a pillow under you, under the baby, and I will feed you. So just that kind of confidence if you give to the mother and the attendants, that we will not disturb. We are just there to help the baby get the much needed colostrum, because ye aage nahi aane wala hai. Colostrum will be there for just the first few days. And if the baby misses out on this opportunity, it's gone. So that's just that kind of wellness, instilling the thought of wellness is something that we do all the time. Let's move on to the next bit of the presentation, which is about suction and compression, right? So we talked about right position. We talked about the 3 Bs. We talked about supporting the baby and the mother well. We talked about sideline. Now what about suction and compression, right? How is the baby creating suction with the cheeks, with the tongue. And for that,
Breastfeeding to occur, a good
so I'll just
breastfeeding to occur, a good latch is required between the infant mouth and the breast. An effective latch requires a few things from the infant. The mouth is widely open with lips that are flared or curled out. The tongue is extended over the gum and under the nipple. The nipple needs to be fully inserted into the mouth, including some or all of the areola. If any of these factors are missing, breastfeeding may become ineffective. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling.
Yeah, so that's I did not put in the complete video, but this is a very, very useful video if you want to see how breastfeeding actually happens inside the infant's mouth. So you see the double pressure of being applied from the cheeks and the tongue, right? The wave-like fashion that we saw. That's very, very important. And if there is any anatomical variation with the baby, this hampers, right? So let's talk about so we talked about the suck and swallow ratio. I've already covered it. Let's move on to the next bit. Why is a shallow latch such a big problem, right? So when we discharge mothers with a shallow latch due to multiple reasons, it can be any reason, right? What happens is there's ineffective milk transfer, the nipple pain continues, the soreness continues, the supplementation continues even at home. Bottle feeding starts happening because even though we discharge babies on cup feeding, we tell them to cup feed, they do it for maybe the first 30, 40 days. The moment the
Miss
milk...
Neha,
Yep.
I'm sorry to interrupt, but many people are commenting that your voice output is a little low. If you can come close to mic, that would be
Sure.
good, I think.
Sure, Priyanka. Is it any better now?
Yeah, it
All
is
right.
better now. Yeah.
Okay, all right. Thank you so much. Thank you. All right. So in case of Priyanka, just let me know if it happens again. I'll be a little more cognizant of it.
It's fine now.
All right. So the supplementation continues, the bottle feeding continues, and eventually we have a lot of factors playing in weaning and combo feeding. Social media is one, family, the lack of support from family, work, going back to work, all of these factors, including policies and including the lack of support across multiple systems. Weaning happens, and then eventually only half of our mothers are able to exclusively breastfeed at the breast. Perceived low milk supply is something that I did not cover because it's out of the scope of the presentation today, but I did want to ensure that we understand that there's a term called perceived low milk supply, where the mother thinks that, okay, my supply is less, the baby is crying more, there's a growth spurt happening, there's a cluster feeding happening, but the P count is fine, the weight gain is fine. So the signs are there, both the pun intended, right? The science is there, the science is there, signs are there, but the mother still chooses formula, and then the same cycle continues, right? So I just didn't want to just mention it briefly, although it's out of the scope of the talk today, but I just don't want to mention it a little more. Okay, so that's easy, right? We understood what a deep latch looks like. We understood how to prepare the baby well, how to support the baby well. So what's difficult? What's actually challenging? Flat nipples? Yes, no, chat. Yes, no, yes, no, yes, no. Flat nipples, are they challenging? Inverted nipples, are they challenging? Will the babies not be able to breastfeed? So the quick answer is nope. Breastfeeding is called breastfeeding for a reason, right? If the baby just feeds on the nipple, it's called nipple feeding. Breastfeeding is breastfeeding. So we want the nipple and the areolar region to go into the baby's mouth, which is why we tell them it's breastfeeding. It can be challenging. You protect your supply, you keep latching the baby, the nipple will eventually evert, right? So as healthcare professionals, I keep hearing this all the time. Aapke nipples banne mein abhi time hai. Let's stop saying that. Let's just pause that statement from today itself. Nipples bane hue hain yaar. It can be a variation, it's not an anomaly. Nipples come in all shapes and sizes, breasts come in all shapes and sizes, right? So let's start saying this. हाँ ठीक है, ब्रेस्ट फीडिंग करा रहे हैं, हम आपको सपोर्ट करेंगे, फुटबॉल होल्ड में सपोर्ट करेंगे, बच्चा नहीं पी पा रहा है, अभी भी चैलेंजिंग हो रहा है, तो हम एक्सप्रेशन स्टार्ट करेंगे, यू स्टार्ट फीडिंग यूजिंग अ कप, right? So all of these things are possible with the right kind of lactation support at the right time. So when is it actually difficult? If this is not difficult, then what is difficult? The first factor is prematurity. So like Dr. Prakash said, prematurity, extremely low birth weight infants. We have, when there is a lack of coordinated suck swallowed cycles, we do the love, lick, latch technique. So what's love? We start KMC as early as possible, right? As soon as the baby is clinically stable enough to do KMC, we start doing that. Lick, NNS, super important. Many NICUs do the KMC bit, but skip the NNS bit, right? Non-nutritive sucking at the breast. Empty the breast completely using a breast pump, give the milk to the baby, still latch on to the nipple so that it start suck swallow cycles. And then finally latching, right? Eventually when the baby is discharged, just a few days before that, start latching the baby. Oromotor stimulation. So something that works very beautifully with extremely low birth weight babies during, just before they're starting breastfeeding. Oromotor stimulation on the outside of the cheeks, finger sucking, all of this just enhances their suck swallow cycles. Football hold works, continued reassurance, expression works, and protecting the mother's supply is essential because mothers are in a lot of stress that's playing on the minds of the mothers. So protecting the mother's supply is super essential. Ensure that they pump at least 10 to 12 times a day in a space that has been provided nicely in your NICU itself, right? So it's still protected, it's still private, and they still have the time and space to pump. Tongue ties. So this is something that has started, that we have started noticing a lot since the recent literature started coming up. So tongue and lip ties, basically any oral anatomical variation or anomaly that inhibits the suck or the suction at the breast, that is something that you need to look out for. So whenever you have a heart-shaped tongue, right? If you look at the first picture, the tongue is just, the frenulum is so tight. This frenulum, ये जो धागा है जीभ में इतना टाइट है कि वो बच्चा जब जीभ चलाएगा तो मदर का जो निपल है वो बार बार रब करेगा पैलेट के अगेंस्ट, and there'll be a lot of soreness. What works? Again, protecting the mother's supply, football hold, and continued reassurance. It will get better. It does get better. Sometimes there is a release that is needed, but that's very few cases. We always assess oral restrictions using functional nature of the ties rather than the appearance. So even in the first case, we did not get a tie release. We just noticed if the baby is being fed well. So that's all. And the baby was fed well. So eventually the baby also learned, right? And there's a lip tie as well. The last bit, clefts, low tone, hypotonia, sleepy baby at the breast, any underlying health conditions, any heart diseases, anything that can hamper the suck swallow breathe cycle, that can hamper the baby feeding at the breast, that just doesn't give the energy to the baby to sustain a good latch. So latching is one, sustaining a good latch is essential. Key takeaways for today. Breastfeeding is a learned skill, right? So let's help the mother learn the skill because there are a lot of interventions that we have done in the beginning, right? So interventions cause interruptions and hence it becomes a learned skill. Tell them that the baby needs to eat a burger. Everybody has eaten a burger. They know how to compress the breast, how to eat the burger, right? Support the 3 Bs and teach the attendant too. So Dr. Prakash talked about a hands-off approach, right? So that's with the mother. I call it the hands-on approach with the father. So hands-on approach with the father. Teach the father. यूपी में बहुत बार ऐसा होता है जो फादर्स हैं उनको हम बाहर कर देते हैं कि आप चले जाइए, हम मदर को बच्चे को फीड कराने वाले। अगर फादर चले जाएंगे तो फादर रात को भी पास में नहीं रुकेंगे, फादर रूम में भी नहीं रुकेंगे, मदर विल नॉट बी एबल टू ब्रेस्ट फीड. So fathers and partners and grandparents play a very important role in sustaining breastfeeding, and that's why their awareness is super important. That is, I think, in the beginning also we talked about. So almost all babies and mothers can breastfeed, but all mothers need motivation, reassurance. The impact. So I began with my story, right? A mother who was struggling, a mother who was not able to feed, mother who was figuring out latching. That's me at day of life 7. Severe PPD, severe anxiety, and that's me at day of life 40, right? Figured out breastfeeding, figured out latching, and sustained breastfeeding for the next 6 months and onwards, right? With toddler feeding. So with that, I'll come to the end of the session. Something that we did not cover today is the latch scoring tool. So if you have a big lactation team in your hospital, ensure that you're scoring the latch with every provider. So something that to read upon, something to know about, something to understand that there is a way to score a latch. I hope this was helpful. With that, we come to the end of the session. Thank you. I'll take any questions.
Thank you, Ms. Neha. It was a very clear and practical demonstration. Correct positioning and deep attachment can completely transform a mother's breastfeeding experience. So, it was a very interesting talk. For next session on KMC and early mother-baby bonding, I would like to invite Dr. Ankur Khare. He is a team leader of Essential Newborn Care and Infant and Young Children Nutrition, Nutritional International UP. He has 11 plus years of experience in maternal, newborn and child health. And he has vast experience in NHM, ICDS and community health program. We welcome you, sir. You can start your presentation.
Thank you so much, Dr. Priyanka. And thank you all for joining today's World Breastfeeding Sessions. And it's very insightful and the journey what we have covered so far. So as we all know that cesarean deliveries actually are increasing day by day. And based on the evidence suggested and what based on the recently NFHS 6 data, it shows that every fifth woman is undergoing obstetric surgeries. I think the percentage is around 19% as per NFHS 6. But the catch is here, we can ensure early initiation of breastfeeding in most of the women. So with the right support of our healthcare team, early skin to skin contact and timely breastfeeding can be ensured. And it can be achieved for most of the mothers and the newborns. So basically today's sessions will show you the practical aspects, especially in the private setup, like what we can do in our routine clinical practice to improve breastfeeding in cesarean birth, along with the role of immediate kangaroo mother care for preterm and LBW babies. And similarly, what we have discussed in the session, that counseling is very important component. So KMC is actually started at the facility, but it has to be continued till home also. So home-based counseling is very important. So our health professionals should be equipped to counsel the beneficiary to continue kangaroo mother care at home. So to take us through this important topics, I would like to invite Dr. Anju Agrawal ma'am, who is a professor and HOD, head of the Department of Gynecology and Obstetrician at KGMU Lucknow. So without taking much time, I request Anju ma'am to deliver the session and the practical aspects of delivery in scissor section along with KMC. Over to you, ma'am, please.
Thank you, Ankur, for setting the scene. And we've just had a very interesting session from Neha ji. So we'll talk about breastfeeding. We've been talking about that the whole evening, and we all know how important it is for each and every baby, and how important it is to start it immediately after delivery. We cannot delay the initiation of breastfeeding. It must be initiated within the first hour after delivery. And the colostrum, which is produced immediately after delivery, is very important for the baby. So here you can see the picture of a baby who has just been delivered. So there are many aspects after delivery which are important. First is delayed cord clamping. The cord must not be clamped before 1 to 3 minutes. तो 1 to 3 minutes में हमें cord clamp करना है. तब तक हम बच्चे को माँ के पेट पर लगा दें, जिससे कि बच्चा माँ की गर्माई भी पाए, बच्चे को ब्रेस्ट मिल्क भी मिल सके. और जब ब्रेस्ट मिल्क मिलेगा, ऑक्सीटोसिन रिलीज होगा, यूट्रस कॉन्ट्रैक्ट होगा, प्लेसेंटा सेपरेट होगा और ब्लीडिंग कम होगी. तो माँ और बच्चे दोनों को फायदा होगा. और इस समय जब बच्चे को हम माँ के पेट पर लेटाते हैं, तो माँ की जो माइक्रोब्स होते हैं स्किन के, उससे बच्चे को इम्यूनिटी भी मिलती है. तो ये माँ और बच्चे दोनों के लिए इट विल बी वेरी हेल्पफुल. So as Ankur already mentioned, the cesarean rate is rising up. particularly the private facilities and the tertiary care centers. And a lot of the rise is due to people demanding cesarean section. They don't want to undergo the pains of normal delivery. But here, let me make you aware that good pain relief methods are available during normal delivery. एंड हम लोगों को पेशेंट्स को उसके लिए काउंसिल करना चाहिए. एपिड्यूरल एनाल्जेसिया है, हमारे यहाँ टेंस मशीन है. तो अलग अलग मेथड्स हैं, वो जो भी मेथड अपनाना चाहें उससे विद मिनिमम पेन दे कैन अंडरगो नॉर्मल डिलीवरी. And normal delivery definitely is very beneficial for both the mother and the baby. लेकिन cesarean में भी breastfeeding immediately start की जा सकती है. Cesarean is not a barrier to initiating early breastfeeding. So this is a picture. हमारे यहाँ cesarean जब होता है, OT में lactation counselors रहते हैं, जो कि जब तक पेशेंट के स्टिचेस वगैरह लग रहे हैं, यूट्रस क्लोज हो रहा है, तब तक बेबी को मदर की ब्रेस्ट से लगाते हैं. तो आप देखेंगे बेबी के वर्नेक्स भी लगा हुआ है, लेकिन बेबी अच्छे से मदर की ब्रेस्ट को सकल कर रहा है. और जितनी जल्दी स्टार्ट किया जाता है ब्रेस्ट फीडिंग, उतनी ही सक्सेसफुल होने के चांसेस ज्यादा हैं. जब हम डिले कर देते हैं, बच्चा बहुत भूखा हो जाता है, कभी उसे टॉप फीड कोई दे देता है, और फिर ना बच्चा कंटिन्यू करना चाहता है ब्रेस्ट फीडिंग, ना माँ करना चाहती है. तो अर्ली इनिशिएशन इज वन ऑफ द वेरी इंपॉर्टेंट मेथड्स फॉर एंश्योरिंग ब्रेस्ट फीडिंग. तो याद रखिए, cesarean does not alter the physiology of lactation, so breastfeeding after cesarean should be the same. There are some barriers की पेन होता है पेशेंट को, थोड़ा सा अनकॉन्शियस कभी हो सकती है, बट यूजुअली आजकल रीजनल एनेस्थीसिया में ज्यादातर सिजेरियन होते हैं, तो पेशेंट इज फुल्ली अवेक. एंड पेशेंट का भी पेन का परसेप्शन बहुत इम्प्रूव होता है जब वो ब्रेस्ट फीड कराती है, एंड शी फील्स हैप्पी. सो अदरवाइज फिजियोलॉजी जो हमारी है लैक्टेशन की, प्लेसेंटा डिलीवर होगा, ऑक्सीटोसिन रिलीज होगा, प्रोलैक्टिन से मिल्क प्रोडक्शन होगा, और कोलोस्ट्रम अवेलेबल होगा. दैट ऑल कंटिन्यूज एज नॉर्मल. और जितना बेबी सकल करेगा, उतना ज्यादा मिल्क प्रोडक्शन होगा, उतनी सक्सेसफुल ब्रेस्ट फीडिंग होगी. So golden hour में I've already discussed, delayed cord clamping is very important, and followed by early breastfeeding and skin to skin contact. These are the three things which we have to do immediately after delivery, except in babies who require immediate resuscitation. बाकी सब बेबीज में हमें ये तीनों स्टेप्स जरूर फॉलो करने हैं. तो इसका वर्क फ्लो कैसे होना चाहिए? सिजेरियन डिलीवरी हो रही है, बेबी जैसे ही आउट हुआ, बेबी अगर हेल्दी है, डज नॉट रिक्वायर resuscitation, then apply the baby to the mother's breast. The surgeon can continue stitching the uterus and closing the abdomen, and the mother and baby, they can enjoy their first breastfeeding experience. But it requires support from the nursing staff, it requires support from the lactation counselors. Without support, this breastfeeding is not possible. उसके बाद जैसा नेहा जी ऑलरेडी इसे बहुत डिटेल में डिस्कस कर चुकी हैं, द डिफरेंट पोजीशंस. जो भी ब्रेस्ट फीडिंग करनी है, हमें ये इंश्योर करना है कि माँ और बच्चा दोनों कंफर्टेबल है. अगर माँ पेन में है, माँ कंफर्टेबल नहीं है, तो बच्चा ये चीज सेंस करता है और वो लैच ऑन नहीं करता है. तो हमें जो भी ब्रेस्ट फीडिंग करनी है, वी हैव टू एंश्योर दैट द बेबी इज नॉट टचिंग द स्टिचेस and the baby is held close to the mother. So the mother may be sitting, have the baby in the football hold, mother may be in the sideline position, or mother may hold the baby in the cross cradle hold. And when there is good mother to child contact, the temperature of the baby is maintained. Because the baby is feeding, the blood sugar of the baby is maintained. Excuse me. There's a good mother-to-baby bonding. There's oxytocin release, which gives a feeling of happiness to the mother and also helps in contracting the uterus and reduces a blood loss. And ultimately, it is a breastfeeding success. And that is where our kangaroo mother care and immediate and home-based comes in. Kangaroo mother care is very important, especially in the preterm babies. But now we are also promoting it in the term babies because it helps to maintain the temperature of the baby, allows a good bonding with the mother, reduces the infections, improves the survival of the baby, and there's a better weight gain. So WHO recommends it as routine care for all preterm or low birth weight infants. It can be initiated in the health facility or at home and should be given at least for 8 hours a day. उससे ज्यादा कितना भी हो सकता है पर minimum 8 hours a day होना चाहिए. And should be started as soon as possible after birth. And it is expected that with this immediate KMC, 25% reduction in mortality will occur when this immediate KMC is initiated immediately after birth. And यहाँ पे एक चीज बहुत important है, without waiting for stabilization. मतलब अगर बच्चे को CPAP या respiratory support भी चाहिए, तब भी हमें उसे KMC देना है. और ये वाले कॉन्सेप्ट पर सबसे पहले सफदरजंग में बना था maternal sick newborn unit. And now in KGMU also, we are having this maternal sick newborn unit, where the babies who are requiring treatment, they may be on CPAP also, but they are nursed with the mother in the KMC position. And as you can see, the mothers are so happy to have the babies close to them. It accelerates the recovery of the baby and it accelerates the recovery of the mother. पहले ये वाला डर रहता था कि ऐसा तो नहीं कि मदर के पास रहने से इन्फेक्शन हो, लेकिन मदर जितना अच्छा केयर करती है उससे अच्छा केयर कोई नहीं कर सकता. तो हमें इंश्योर करना है कि हमारे यहाँ सब हॉस्पिटल्स में इमीडिएट केएमसी स्टार्ट हो. इमीडिएटली आफ्टर डिलीवरी बेबी को मदर के एब्डोमेन पर रखें. एम फॉर 20 hours a day, minimum 8 hours a day. Another important thing is कि केवल मदर नहीं ऐसा है कि देना है, कभी कभी होता है मदर इज सिक, मदर may be in the ICU, then other family members can give the KMC while the mother is recovering. That other family member may be a father, maybe a grandmother, or maybe anyone else in the family. But we have to ensure zero separation and protect breastfeeding. In the preterm babies, it is important we can give these babies donated milk from the milk bank, which is again available in a hospital. And that is again a boon for the preterm babies where the mother is sick. So how can we ensure that this immediate kangaroo mother care works? For the health system and facility, the common barriers are limited space and privacy. So we have to ensure, हो सकता है हमारे यहाँ बहुत 5-star facilities ना हो, but we can definitely put curtains in between different beds. We need to train our staff and we need to train our staff in the OT and ICU and in the postnatal ward. And we need to develop standard operating procedures for the same. When they go home, they have to maintain the kangaroo mother care, and we need to train their family members also. Breastfeeding and KMC, both are successful only with societal support. फिर घर जाके होम बेस्ड केएमसी Every family member has a role, as I mentioned. मदर स्किन टू स्किन कांटेक्ट प्रोवाइड करती है, कभी मदर नहीं कर पा रही है तो फादर, ग्रैंडमदर सब प्रोवाइड कर सकते हैं, और मदर भी कर रही है तब भी फादर एंड ग्रैंडमदर दे हैव टू सपोर्ट द मदर इन गिविंग द बेबी केएमसी. सो यहाँ पर हमारा फैमिली काउंसलिंग बहुत इंपॉर्टेंट है. अगर पूरी फैमिली नहीं पार्टिसिपेट करेगी इसमें, ब्रेस्ट फीडिंग में भी मदर को प्रॉब्लम्स आएंगी और केएमसी में भी आएंगी, और हमारी मेटर्नल और न्यूनेटल मोर्टेलिटी इसी तरीके से ज्यादा रहेगी. तो अगर हम मेटर्नल और न्यूनेटल मोर्टेलिटी को कम करना चाहते हैं तो हमें बहुत इंपॉर्टेंट है ये अर्ली इनिशिएशन ऑफ ब्रेस्ट फीडिंग, exclusive breastfeeding for 6 months, and KMC with family support. We should promote all of these. तो सिजेरियन के बाद हमें क्या करना है, क्या नहीं करना है? We have to avoid routine formula supplementation without a medical indication. There are very few medical indications for formula supplementation. We have to avoid routine mother to newborn separation after cesarean. डिलीवरी के बाद, सिजेरियन के बाद भी बच्चा माँ के साथ लेट सकता है as long as both are well. We don't need to delay skin to skin contact till the baby is fully stable. बेबी को अगर रेस्पिरेटरी सपोर्ट की भी रिक्वायरमेंट है, still we can give skin to skin contact, and as I showed you in the maternal newborn sick newborn care unit. Bottles or pacifiers are not to be given, and breastfeeding counseling should not be delayed. Breastfeeding counseling हमें कब करनी है? एंटीनेटल पीरियड से करनी है, और बल्कि पहले से भी. हमें जब भी महिलाओं से बात करने का मौका मिले, हमें किशोरियों से बात करने का मौका मिले, हमें उन्हें काउंसिल करना चाहिए कि उन्हें ब्रेस्ट फीडिंग जरूर करनी है. क्या रिकमेंडेड प्रैक्टिसेस हैं? हमें एक्सक्लूसिव ब्रेस्ट फीडिंग सपोर्ट करनी है विद स्किल्ड लैक्टेशन काउंसलर. जीरो सेपरेशन मेंटेन करना है. आजकल आप लोग को पता है बेबी फ्रेंडली हॉस्पिटल इनिशिएटिव में पहले के जमाने में मदर के बेड के पास एक कॉट लगा रहता था. नाउ देयर आर नो कॉट्स इन एनी ऑफ द हॉस्पिटल. अगर कहीं है तो नहीं होने चाहिए. द बेबी शुड बी लाइंग विद द मदर. We must initiate skin to skin and immediate KMC as early as possible. Encourage direct breastfeeding, avoid artificial teats, and start counseling antenatally, reinforce right after birth. तो सिजेरियन के बाद जो ब्रेस्ट फीडिंग फेलियर होता है, ये ड्यू टू लैक ऑफ एडिक्वेट काउंसलिंग and lack of adequate motivation from the hospital staff hota hai, not due to the surgery. So we have to overcome this. तो हमें क्या करना है? Start skin to skin contact within the golden hour. Make immediate KMC routine. Do not delay waiting for stability when clinically appropriate. Aim for KMC at least 20 hours a day, but minimum 8 hours a day. Continue the KMC at home, and definitely teamwork makes a difference. One more thing which I would like to add at this time, if we want our breastfeeding program to be successful, we also need to offer postpartum contraception. Otherwise, होता ये है कि 3 महीने बाद पेशेंट प्रेग्नेंट होके आ गई, ना वो breastfeeding कंटिन्यू कर सकती है, ना वो जो नया फीटस उसके यूट्रस में ग्रो कर रहा है उसे एडिक्वेट न्यूट्रिशन मिलेगा. सो postpartum contraception with a birth spacing of 3 years is mandatory to permit successful breastfeeding. Thank you very much.
बोलिए।
Was I audible? Because I cannot hear anything now.
Yes, ma'am, you were.
Yes, ma'am.
Thank you.
Clear, loud, and audible.
Dr. Priyanka, should I join? Should I share?
Hello, ma'am.
Hi.
Thank you, ma'am, for the wonderful session. So now I invite Dr. Shalini, ma'am. She is professor in pediatrics and neonatology in KGMU, and she has multiple publications in her credit. Ma'am will be speaking on practical breastfeeding challenges and how to solve them. Probably a very important session for the today's talk.
Is my screen visible?
Yes, ma'am. It is visible.
Okay. So a very good afternoon, everyone. First of all, I would like to thank UP NNF for organizing for this CMA, which is on a very pertinent topic. And the most importantly, I want to thank involving Dr. Anju ma'am also, and listening such a talk from a OBGY person is like a thing that I'm very optimistic, especially for my institute, that the breastfeeding and other things what's happening, and it can't be possible without the support of the OBGY person. And Anju ma'am has taken such a talk that each one of us should do as a pediatrician and neonatologist. Thank you so much, ma'am, for an excellent talk. And now today I'm going to... Yes, ma'am. So now, as give the topic which is given to me, that the breastfeeding challenges, because ये कहना बहुत आसान होता है breastfeeding कराइए, और जैसा कि नेहा जी ने भी बताया कि बहुत ट्रिकी तरीके से उन्होंने इंटरेस्टिंग तरीके से कराया, बट फिर भी हम ये देख रहे हैं सर्वे के हिसाब से कि हमारे 6 मंथ के स्टैटिस्टिक्स जो हैं वो अराउंड हाफ हो गए हैं. So which is really very a matter of concern for all of us. And I would like to start my talk with some physiological aspect also, so that first of all, the doctors and the nurses are convinced that there is nothing that the milk can't be produced, because the nature's strategy is such a strategy that there is nothing when one mom can produce, the others can also. But what are the real scientific, the connections, the things, the crux we want to work the mothers on, that we quickly make them, to produce breast milk adequately for their babies. So I'm just going into the stage, which is like the production of the milk glands. So there are 4 stages when we see कि जब हमारा breast बन रहा होता है, तो ये breast का prenatal stage पे ही ये breast female उसके अंदर mammogenesis हो जाती है. Then this from mid pregnancy, as Dr. Neha also Neha ji also told, that there is differentiation and formation of the secretory gland, and that continues till day 2, and for 2 days there is a little secretion of colostrum. Then from day 3 their lactogenesis starts actually, and so the mother feels the tense breast on day 3. So first 2 days are very challenging, when she doesn't feel a tense breast for 2 days, and she is very apprehensive that my milk is not there. Day 3, the milk coming in occurs, and this continues to rise exponentially from day 3 to day 8. बट एक बात बहुत इंपॉर्टेंट ये होती है कि जो गॉड की स्ट्रेटजी है, द बेबीज स्टमक साइज इज सिमिलरली इंक्रीजिंग. If we say a baby's stomach size, it is like a cherry size, a little cherry size, and the milk and colostrum which is there around 1 ml, 0.5 ml, or maximum 2 ml in every feed is adequate to fulfill the requirement of the baby. और फिर ये फेज आता है आपका डे 9 पे गैलेक्टोपोइसिस, जो कि उसको एक मदर को अच्छे से मिल्क प्रोड्यूस होता है। इस समय वो अपने बच्चे के लिए भी प्रोड्यूस कर सकती है, डोनेट भी कर सकती है, एंड इवेंचुअली ये फेज लैक्टोजेनेसिस 3 चलता है टिल द मदर फीड्स। और एक और बहुत इंपॉर्टेंट बात है कि ये सेल्स तब तक नहीं खत्म होती हैं जब तक कोई जना 40 दिन तक अपने बच्चे को दूध बिल्कुल ना पिलाए, ना निकाले, और उसके अंदर फिर वो एपोप्टोसिस शुरू होती है। सो अगर हमने कहा कि एक मदर जो है वो बच्चा पहले आ गया KGMU और वो 6 दिन के लिए मदर अलग हो गई, तो अभी भी when she comes back she can relactate, and these are the stages which we need to know so that we have very clear thing that this is similar in all the mothers which the god or the humans are. सो ये हमने पहले ही बताया कि ये प्यूबर्टी से लेडीज जो गर्ल्स होती हैं उनके अंदर होता है ब्रेस्ट बड बन जाती है इन हार्मोन्स के थ्रू, ईस्ट्रोजन एंड प्रोलैक्टिन एंड प्रोजेस्टेरोन के थ्रू, एंड द मैमोजेनेसिस स्टार्ट्स। देन द मिड प्रेगनेंसी टू डे 2 इज लैक्टोजेनेसिस 1। डे 3 से आपका जो है मिल्क कमिंग इन हो गया एंड डे 3 तक एक्सपोनेंशियली बढ़ गया, एंड देन till galactogenesis happens. After that, that is lactogenesis stage 3, till the mother is feeding. So अगर मदर को और हम लोग को ये बात पता है तो ये हसल जो मचता है, जो टॉप फॉर्मूला लिखवाने का, वो मचता है शुरू के 2 दिन और शुरू के 3-4 दिन, बिकॉज द मदर्स आर नॉट एक्चुअली, उनको दिख नहीं रहा है कि हमें जो है 100 ml दूध हमारे बच्चे के पेट में जा रहा है, और उनके दिमाग में उनको ये लग रहा है कि भाई मेरे तो बच्चे को दूध ही नहीं मिल रहा, और वो हमारे पीछे पड़ जाते हैं कि आप हमें पाउडर लिख दीजिए। चाहे हम कितनी भी कोशिश कर लें, दे विल चेंज द डॉक्टर्स, बट देयर जिद इज द सेम कि प्लीज डू राइट अ फॉर्मूला सो दैट आई कैन गिव माई बेबी 100 ml, 120 ml of milk. So now the second important thing is that we should know the 2 reflexes. All of us are knowing, but we should also tell the mothers that it's a matter of brain. It's a matter of brain. और इसमें अर्ली इनिशिएशन की बात करी थी मैम ने कि अर्ली इनिशिएशन करना है हमको, जो भी बहुत ही कम है, 50%, 40% रेट्स हैं उसके। वो इसलिए हो रहा है क्योंकि ये जो सिग्नलिंग होनी है टिल द पोस्टीरियर पिट्यूटरी, इट कैन हैपन ओनली इफ द बेबी सकल्स एट द ब्रेस्ट, एंड वो दिमाग के अंदर इंफॉर्मेशन गई एंड ऑक्सीटोसिन इज रिलीज्ड, and then of course when the suckling occurs, when the baby suckles many times, here one point is very very important कि जितना फ्रीक्वेंसी होती है, स्टडीज में भी प्रूव्ड है, जितनी फ्रीक्वेंसी है, अगर हम बच्चे को अपने आप पिला भी रहे हैं दूध पहले और दूसरे दिन, जब हमारे पास भाई मिल्क बहुत कम हो रहा था, लैक्टोजेनेसिस 2 की फेज चल रही थी, और जितना भी हम क्या कहते हैं दूध पिला रहे हैं, उसमें फ्रीक्वेंसी बहुत इंपॉर्टेंट है। मदर क्या करती है, एक बार दूध पिला के बस लगा के बैठ जाती है, और वो कहती है कि मुझे अगले दिन के लिए वेट करती है कि मैं डॉक्टर साहब से बस दूध लिखवाना है मुझे। बट द मोस्ट इंपॉर्टेंट इज दैट उसको बताना है कि आपको भाई 24 घंटे में 12 बार आपको लगाना है कम से कम। सो जितना फ्रीक्वेंट आप बार बार लगाएंगे उतना स्टिमुलस जाएगा, और स्टिमुलस बेस्ड मोर प्रोडक्शन ऑफ प्रोलैक्टिन एंड ऑक्सीटोसिन एंड मोर प्रोडक्शन ऑफ मिल्क विल हैपन एंड लेट डाउन विल हैपन। सो दैट इज द इम्पोर्टेंस कि हम उनको बताना है हमें कि आपका जो ये हार्मोन, आपका तो बेबी हो गया है बट आपके ब्रेन को पता नहीं चला है कि अभी बेबी हुआ है आपका। So for that you have to give them stimulus, and to tell the brain the stimulus is not showing the baby but actually touching the baby, suckling at the areola is the way you can tell your brain that now you know you are going to produce prolactin and oxytocin so that the breastfeeding will happen. अब क्या चीजें हैं बहुत इंपॉर्टेंट है, प्रोलैक्टिन जैसे ही ब्रेस्ट के अंदर भरा हुआ ब्रेस्ट देखता है वो एक नेगेटिव फीडबैक जाएगा, प्रोलैक्टिन बंद हो जाएगा। जितना आप मिल्क निकालोगे, जितना वो फ्रीक्वेंट करेगा, और नाइट टाइम में प्रोलैक्टिन का चेंज होता है जो उसकी सर्कैडियन रिदम होती है। सो हाउ जितना ज्यादा आप एक्सप्रेस कर रहे हो, ऐसे ही प्रीटर्म फॉर्मूला में वी हैव अ प्रीटर्म बेबीज में वी हैव अ रूल, वी टेल अवर मिल्क बैंक स्टाफ कि इस बेबी में मुझे 8 टाइम जो है कम से कम एक्सप्रेशन चाहिए, इन विच 2 times it should be in the night, so that the prolactin is producing. अगर आपने एक भी दिन नील ओरल बच्चे को रखा and mother is not emptying her breast, if you don't have the milk bank you can't store it, you can even, मदर कहीं और है, उनको हम कहते हैं कि आप हटाते रहिए, अपना दूध निकालते रहिए, एक तो रीजन ये है कि उनका खाली नहीं होगा, तो अगले दिन जब आप 3 दिन बाद नील ओरल रखने के बाद में उनको आपको NEC लग रहा है, स्टेज 1 लग रहा है, तो आप जैसे ही शुरू करेंगे अब माँ के पास कोई दूध नहीं होगा, बिकॉज आपने उसको एम्प्टिंग नहीं कराया. एंड आइडियली तो उस मदर का एक्सप्रेस करके वी शुड हैव अ स्मॉल कॉर्नर व्हेन शुड बी अ ब्रेस्ट पंप, एंड एक्सप्रेस करके आप 24 आवर्स तक आराम से फ्रिज के अंदर जो है स्टोर कर सकते हैं, सो दैट नेक्स्ट टाइम व्हेन यू हैव द मिल्क, मदर्स मिल्क. एंड हिंड्रेंस, incorrect positioning, painful breast, all these conditions, they are the hindrance, and incomplete emptying is the biggest hindrance for this hormone. Same is the oxytocin. Oxytocin is a happy hormone, feel happy hormone. So mothers should be welcomed. Mother newborn care unit आपने KGMU का देख लिया है. हम लोगों का बहुत ही, we have an excellent experience of mother newborn care unit. The mothers are coming in, and as they keep the babies close to them, so baby and mother should be close. That is the only key to produce breast milk. And mother thinks of the baby, and mother should be 24 hours welcome. कहीं पे भी ऐसा नहीं होना चाहिए कि mother जो है वो शीशे से दूर से बच्चे को देख रही है. And she should be allowed in the daily activities. CPAP पे अगर baby उसके settings नहीं बढ़ी हुई हैं बहुत ज़्यादा, and baby is maintaining saturation, तो CPAP is a normal stable baby. CPAP is not a contraindication, not at all. The people are doing an NIPPV on ventilated. We are not going that way, but level 2, all preterm level 2 babies, they definitely, they deserve, it's a norm, they're normal, they deserve to have the milk by the OG feeds and by the kangaroo mother care. अब मदर को ऑक्सीटोसिन के लिए एक और बहुत इंपॉर्टेंट है द सपोर्ट ऑफ द फैमिली. That is very important, the support of the nurses around, and she is very confident. Some people, the back massage, a very good environment in the MNCU, maybe there is some music going on in the back. All these happy things makes her produce more oxytocin. Whenever she's stressed out, worry, doubts in her mind that what's going to happen, कोई उनसे बात नहीं कर रहा है, तो ये सब चीजें कम हो जाएंगी. सो ये चीजें हमने देखा कि देर आर सर्टन, दीज आर ऑल वेरी साइंटिफिक थिंग्स. जैसा कि हमने पहले भी सुना कि अब ये कोई ऐसी चीज नहीं हो गई है कि ये बड़ा, इट इज नेचर, बट नेचर हैज सच अ इंटरेस्टिंग साइंस एसोसिएटेड विद इट, एंड इफ वी नो इट वी हैव टू मेक प्रोटोकॉल्स इन अवर यूनिट्स. जैसे कि मदर्स आने अलाउ नहीं है, मदर को बहुत ज्यादा रिस्ट्रिक्शन है, मदर से हम काम नहीं करा रहे. ऑल ऑफ अस लेट्स थिंक अबाउट इट. क्या हम ये चीजें कर रहे हैं कि जिसके कारण हमारे यूनिट में मदर्स जो हैं वो डिस्चार्ज पे बच्चों को फीड कराते हुए नहीं जाती हैं. सो ये पूरा एक फ्लो चार्ट जो अभी हमने डिस्कस किया, that how all these things are linked to produce a successful breastfeeding baby. So we have already discussed. Now the types of the human milk, we all know that there is first 3 days colostrum, very, very important, rich in antibodies, then transitional milk, and eventually the mature milk, which is 14 days. After 14 days, when there is an initial, there is a lot of water, and later part is rich in fat. So it is very important to say that it should be a demand feeding, और बच्चा जो है अपने आप मिल्क छोड़े तब आपको बच्चे को हटाना है. सो दैट इट कोई हम मिनट नहीं जस्टिफाइड है, ड्यूरेशन भी नहीं जस्टिफाइड है. इट कैन डिफर फ्रॉम बेबी टू बेबी, बट द मोस्ट इंपॉर्टेंट इज completely empty one side of the breast and then take the other breast. We can't say कि ये 2 घंटे में पिलाइए, 3 घंटे में. बच्चे, it can really vary between the babies. So now the challenges. So the most important challenge is, to early initiation of breastfeeding is like, what are our resuscitation policies? Because most importantly, we have to see that only the babies who are really requiring resuscitation, they are separated from the mothers. Because as soon as you separate, ये early initiation वाला काम नहीं हो पाएगा. और अगर early initiation नहीं हुआ तो आपका डिस्चार्ज पे ब्रेस्ट फीडिंग होने के चांसेस बहुत कम हो जाएंगे. सो जब हमने अपने यहाँ रिव्यू करे ये रेट्स वगैरह, तो वी थॉट कि लॉट ऑफ बेबीज, वी आर डेली राइटिंग द गोल्डन आवर डन, इतने बेबीज डिलीवर हुए, इतने बेबीज में हमारे यहाँ गोल्डन आवर नहीं हुआ. सो व्हाई नॉट, उनके रीजन लिखने हमने शुरू किया, एंड वी सॉ दैट देयर इज अ लॉट ऑफ बेबीज व्हिच वर सेपरेटेड फॉर ट्रिवियल इश्यूज. उसको ऑब्जर्वेशन करने के लिए ले आए. The baby, they had 4 deaths. So this time we are just observe that the babies are separated just for, small tricky things. And then early initiation was not done. So let's, assure that this normal birthright of the baby is not, they should not be devoid of this thing. This is a very important picture which is showing the 9 stages of the breast crawl, in which you can very well see here that in the stage 4 and stage 3, the baby is very active. There is a birth cry, then there is a relaxation, then baby is awakening and he plays with the breast, he is active, and then apne aap wo apne haath ke amniotic fluid mein the smell is the same as around the breast, and then he suckles and familiarized suckling occurs, stage 8, and eventually baby sleeps. So this is a normal thing which the babies don't get this this king-like treatment because we used to separate them. वो जाकर के कहीं और उनको हम NICU में observation के लिए ले जाते हैं, and then उनको formula milk दे दिया जाता है. So I think this is very, very important part as a pediatricians, that we are really ensuring that the resuscitation के कारण बिल्कुल सही appropriate candidates को ही अलग किया जा रहा है हमारे यहाँ. सो स्किन टू स्किन कॉन्टैक्ट मैम ऑलरेडी ये कर चुकी हैं. हमें कई बार विटामिन के लगाने के लिए अलग कर देते हैं, कई बार क्या कर देते हैं कि जस्ट फॉर weight is not a important thing. It can be taken any time in the first 24 hours, and vitamin K can be given baby को early initiation करते करते ही आप आराम से लगा सकते हैं. Then rooming and demand feeding, all that should be done. The baby should be on the mother bed 24/7. They should be together. And hunger cues, early hunger cues based feeding is very important. Before the baby becomes so restless and cries badly, that is not the time to feed. It is good to identify the early cues like the rooting, hand to mouth movements, so that you understand that now the baby is hungry. And the mothers had to feed 8 to 12 times in 24 hours, and this supply demand cycle has to meet. Post cesarean strategies, madam has already told, but we have I also want to add that how we do that. Most of the mothers are in spinal, but in the spinal we can very easily do like in this baby we are doing, and sometimes there is no space in the front. So from the back, the lactation counselor goes and in a football position, she's holding the baby and she starts that breastfeeding. And believe me, the type of videos and the type of suckling the babies do on the OT table, it is an eye opener. I have such a nice videos of these in the cesarean deliveries. And nowadays, even so many VIP deliveries and so many educated mothers, and even our residents, when they become moms, they feel so emotional that I'm so happy that on my cesarean, when it was being done, we started the feeding, and then eventually it continued and sustained as a exclusive breastfeeding. These points are well taken, but I would like to say that we can just memorize to the nurses like 4S for the position, that is Seedha, Samne, then Sameep and Sahara. हम अपने लैक्टेशन काउंसलर्स या जो भी हमारे नर्सेज हैं उनको पोजीशन ठीक करने के लिए यूज करते हैं. एंड क्रॉस क्रेडल इज अ वेरी गुड फॉर द स्मॉल प्रीमी बेबीज इन विच वी cross so that we hold the neck in a better way. In a stable other babies we can do the cradle and then football hold and other things. We can do even football in the lying down position, because there is a myth ki lying down position mein, side lying mein position mein the babies can aspirate. If a baby is mature enough more than 34 weeks, the sucking, swallowing and respiration is well coordinated and they will not do so. And the 4 signs of good attachment, the mnemonic can be calm, that is chin touching the breast, areola visible only above, not below, lower lip is turned outward, and mouth is wide open. So now we have to, whenever in the lactation counseling is there, the mother comes and she says ki mujhe doodh nahi ho raha hai. So most importantly, we should have a lactation counseling room where we need to see the attachment. Mostly position is many times correct, but attachment is very wrong, because they usually attach on the nipple. And here we very rightly said that it is breastfeeding, it is not nipple feeding. And so we have to observe, then explain, then again demonstrate and support and reassess. There is also many objective scores to check for the latch, like latch score, which is very most widely used bedside tool. Other tools are also there. So in the latch score, the various components are seen, like latch, the baby is too sleepy or reluctant and no latch is done. By multiple attempts, if the latch, he is stimulated to suck. And number two is when the a very good grasps breast, tongue is down, lip flanged, and rhythmic sucking is there. A say it is audible sucking. If it is, there is no audible sucking. A few audible sucking you found with stimulation, and there is a good audible sucking. Type of nipple, inverted, flat, or everted. Then comfort, how the mother is feeling about the comfort, and H is to the hold, how she is positioning the baby. So then it is a very important to ask about that what is the duration and frequency of the feed. There is no strict rule that how long each feed. हम ये नहीं कह सकते कि आपको 15 मिनट पिलाना है. Some babies they feed very quickly. Some babies like preterm babies they take longer. So what matters is that the baby should be finishing one breast completely to ensure the hind milk, which is richer in fat and supports growth, is fed. And usually they vary from 10 to 20 minutes per breast, and total number of feeds should be minimum 8 times a day, including the night feeds. So the main problem is the not delayed lactogenesis, that's these 3-4 days, or not enough milk, and then breast engorgement, mastitis, abscess, sore nipple. And many mothers, they have flat and inverted nipples, and sometimes the refusal to feed. I will quickly take these things. So I will just come, I have already explained कि delayed lactogenesis जो है वो एक normal physiological चीज है. 2 दिनों तक जो बच्चे की requirement है उस हिसाब से milk आता है. But sometimes it can extend. Day 3 पे भी नहीं आया, थोड़ा सा और लंबा ये खिंच जाता है. So this can be related to the maternal illness, stress, medications, delayed initiation, early initiation nahi hua, or separation of the baby and mom. So, but as soon as you correct all these points, it eventually, gets corrected. So then there is something which is called as the self-reported insufficiency of the milk. And I think जो mostly mothers आती हैं OPD में, उनको most importantly thing is that the baby is not getting milk and please write me the formula. It is not that they're not, when you ask all the questions related to feeding, is the baby sleeping for 2 hours, producing 6 times urine, the weight gain is adequate, he's plus 500 grams. Sometimes the babies are growing more than even 800 grams from the birth weight. So then, it is only the psychological brain, their only perception about it. And you have to just counsel them, and counsel them in such a way that they are not going to another doctor to write the formula. And the most important is to tell that there's a weight gain in the baby. बच्चे का वेट कैसे बढ़ जाएगा अगर आपका दूध नहीं मिलता, तो बच्चा जो 2.7 का है वो 3.2 kg का, 3.5 kg का भी कैसे हो जाएगा. And all these points we have to tell them. And I think the weight gain is a very objective thing. आप उनको बता सकते हैं कि ये चीज है. Then there is a problem which is called as engorgement. So whenever the babies are there in the NICU, the preterm babies, many times the milk is stopped. And a very important reason why, because mostly preterm babies will be on the CPAP, and CPAP belly is a very common reason, to start antibiotics, stop milk, and when you go in the rounds, you see that the abdomen is distended. So please see that, the CPAP belly is not the cause of stopping feed in your setup. And in case really you're thinking the baby is sluggish and there is suspicion of NEC, then the mother should express. And in cases the mother is not able to express, sometimes they're getting engorgement. In that case, the warm compress can be applied and perform the gentle massage. Correct position and attachment. Many times she is not able to attach well. So that means the breast is not completely emptied because of the the breast size becomes so huge because of the fullness, the baby cannot latch well. So then hand expression or pump based expression should be there, and avoid very tight clothing and the pressures on the breast. And eventually if there is a so much of there is inflammation, then antibiotic course or even the surgical incision and drainage may be also required. The mastitis case is that when there is a inflammation actually sets in, and here you need a course of antibiotics, especially if the fever is there and the breast abscess is there, then the drainage is required. Sore nipple is a very, very important problem, and the most important is improper attachment. So we have to see that she's latching on the areola and not the nipple. And for this, we have to just correct the attachment, and then apply hind milk over the area, and it will correct on its own. Sometimes some mothers, they wash the breast every time they feed with the soap or some antiseptic wipes, etc. So that is also not required. Only single bathing is required, because the natural oils, they are washed with bathing and too much of wash, and that basically cracks the nipple, and it's a very painful condition. And if it happens to any mother, then she is not going to feed the baby because of the pain. Then flat and inverted nipple, ये भी जो है एक तरह का perception वाली चीज है. निपल की के ज्यादा प्रोजेक्ट या कम प्रोजेक्ट होने को ये डिफरेंट नाम दे दिए गए हैं, बट इसके कारण ब्रेस्ट मिल्क के बनने या इंजेक्शन में कोई फर्क नहीं पड़ता है, क्योंकि हम लोगों ने वो देखा, वो सारे हार्मोन, स्टिमुलस and everything is same for all the mothers. So flat nipple do not interfere with the sucking. The baby takes a large mouthful of breast tissue beneath the areola and not just the nipple tip, because वो पूरा areola आप लगाते हो, आप nipple से तो suckle करा ही नहीं रहे हो. तो अगर बार बार माँ के दिमाग में आपका फ्लैट निपल है, आपका फ्लैट निपल है करके डाल दिया जाएगा, तो उसका प्रोलैक्टिन जीरो हो जाएगा, कॉन्फिडेंस जीरो हो जाएगा, ऑक्सीटोसिन जीरो हो जाएगा. And manual rolling can be done, and negative suction only with a syringe by mother herself, and never do it in the antenatal period, because this can even do the uterine contraction under the guidance of a trained lactation counselor. So manual rolling is enough. Then these are the things like baby can be crying all the time, but he's not hungry. So we have to tell the parents and attendant and पूरी family, क्योंकि baby रात भर रोता है, तो उनको यह है कि डब्बा लिख दीजिए. उनको बताना है कि बच्चे के कम्युनिकेशन का यही एक रास्ता है, वो खेलना चाहता है, कभी उसको कोलिक होता है, sometimes he is just crying because of the wet nappy, etc. So these are the various reasons why the baby cries. He is gaining adequate weight, and there is no issue with the breastfeeding, and the reassurance what is required. Then of course illnesses हम लोग नहीं देख रहे हैं कि अगर real illness है, then we have to take care of that. Relactation का मतलब है कि mother who has stopped breastfeeding or the significantly reduced breastfeeding, then relactation can be done, and there is a frequent breast stimulation, maternal motivation, and continuous support from the healthcare team is required. And relactation is possible with most of the women with patience and persistence. It can take 2 to 6 weeks of persistent effort. And the role of the galactogogues is uncertain. Like जो हम लोग बहुत सारे आयुर्वेदिक मेडिसिन है, it has got a placebo effect and it has got no scientific evidence. But then if the mother is want to take some natural locally available things like ramdane ke laddu and milk and that gond ke laddu, so they should be all allowed. But the products which are there in the market, they should not be too much marketed. Now counseling is very important. When you counsel, we have to do, actually there is a G, there is a GAL pack of counseling, and this G is first is greet, and then you have to ask the problem. Although ये सब चीजें बहुत बड़े सेशन की बात है, but कई बार हम एक शॉर्ट सेशन में भी मदर को अच्छे से काउंसल करना पड़ सकता है. So we have to really listen to them very carefully, while you are also having a verbal and non-verbal gestures with good eye contacts and not looking at your mobile. And among the whole story, what she told, you have to listen and take some keywords on which you start the praising that you are doing this thing before you starting condemning her that you're not doing this correct. And then you correct, advice regarding the position, attachment, etc. And in the last, you have to really ask, can you just tell me how will you hold the baby or how will you attach? Rather than ki aapko samajh mein aa gaya, yes or no. It should be an open-ended question. So GALPAC is very important, and your non-verbal thing is very, very important in counseling. So I think we have to take the complete history and maternal support. We have to tell that frequent suckling karana hai, 8 to 12 times in day, skin to skin contact, correct latch and positioning, breast stimulation, expression, especially preterm babies are on, births are on rise. So every neonatal unit, if is not going to support these mothers in expression, there is no a designated area where there's a privacy, where there is a support breast expression manual and pumps are there. So then the breastfeeding will be a zero thing for that particular unit. So it is a very important to make a small area for supporting the breastfeeding, and then of course on the weight etc. we have to do the follow-ups. Building confidence and support is very important. So preterm neonates बहुत ज़्यादा हो रहे हैं, तो उनमें किस तरह से हम कर सकते हैं that the non-nutritive sucking is very important. We should do that. Like after completely emptying the breast, the baby should be allowed to suckle. And also the oromotor stimulation, like gentle stroking of the lips, gums and palate and massage. So this will stimulate the reflex activity so that their sucking swallowing reflex coordination occurs early, and then you can start doing gradually the katori spoon and the breastfeeding. This I will not take, but I will just want to say that any baby who is more than 1 kilo or more than 28 weeker, and definitely more than 30 weeker babies and more than 1250 if the baby is stable, please start with a full enteral feed, that is 80 ml per kg per day, by mother's own milk, or if it is not there, then donor human formula. And if it is not there, a small amount of colostrum plus preterm formula, but don't give IV fluids to these babies. And for the smallies, that is less than 1250 or less than 1 kg, we can start with a minimal enteral nutrition, and no baby should be, nil oral in your unit. And do write on a dashboard that how many babies are nil oral on mixed feed, on complete breastfeeding. And the nil oral baby should be not like in my unit of 30 bedded intensive care, 1 or 2 are always nil oral. And I do ask the residents and team to write what is the reason why the baby is nil oral. Maternal infection. So I will just want to say, इंडिया जैसे कंट्री में जहाँ पे लो मिडिल इनकम कंट्री है और हमारे पब्लिक सेक्टर में स्पेशली, there is no infection in which breastfeeding is not given. Even in HIV exclusive breastfeeding is given 6 months because the formula feeding is not affordable for many people, and then the mixed feeding and risk of dying from diluted formula and malnutrition is more than the HIV per se. So HIV, coronavirus, varicella zoster is only contraindicated if the vesicles are there only above the this thing nipple, or during this 5 days and 2 days. Then express breast milk can be given if the vesicles are all other part of the body. Hepatitis B, breastfeeding is continued. Hepatitis C, infection in the mother, breastfeeding is continued. And tuberculosis also, it is accepted, except in the initial contagious period where you can give the expressed breast milk, and also the mother can just apply a mask. So major takeaways is lactation is a demand-based hormone-driven process requiring early initiation and frequent milk removal. Correct attachment and positioning are critical for effective breastfeeding, prevention of complications. And most breastfeeding problems are preventable and manageable. And true lactation failure नाम की कोई चीज नहीं होती है, तो हमें देखना पड़ेगा कि फिर भी हमारे breastfeeding rates कम क्यों हैं. And it is very important to support especially the preterm and sick newborns to expression etc., so that they are given breastfeeding only by gavage feeding. Empathetic counseling and family support will improve breastfeeding outcomes in preterm and sick babies. Thank you so much.
Thank you, ma'am. Thank you for simplifying the frequently encountered challenges. It was a wonderful talk. For next session, I would like to invite Dr. J.K. Gupta sir. He is President IAP Kanpur to speak on the IMS Act and how to make it more effective. It is a very important section because promoting breastfeeding is not enough unless we also protect families and healthcare systems from inappropriate commercial influence. So it is a very important talk ahead. We invite you, sir. You are not audible, sir. We are not able to hear you.
Please unmute yourself.
Sir, you need to unmute yourself, sir. We are not able to hear. Sir, we are not able to hear you, sir. So you are not audible, sir. Meanwhile, we can take some questions, Shalini ma'am. Would you like to take up some questions?
Lactation consultant comment on nursing strikes by baby. Is it something which is true or just hypothetical?
Can you repeat your question?
I was just asking whether nursing strikes by babies are true entity or they are just hypothetical situations.
I have not come across any time. Shalini
What
ma'am,
nursing strike? What do you? I don't know.
It is some.
Okay.
Yeah, ma'am. Actually, I am an obstetrician.
Ji.
Because I am also means very much into counseling for breastfeeding and all that. So I was just preparing a PPT for challenges during breastfeeding. So I came across so many conditions. Nursing strike is the babies will just refuse to take large on breast milk and feed. It may be due to some painful condition, as very well highlighted by previous speakers. But sometimes it happens, and then if you keep on, continuing breastfeeding, they will just get over it. So that was something interesting. I thought so many experienced people are here. I will just ask them. Thank you so much.
Okay.
Can I take it up, Shalini ma'am?
Yeah.
Hi, thank you so much for the question, Anita ma'am. Yes, nursing strikes do happen when there's a lot of force feeding at the breast because the mothers are trying to do a lot of things, right? कि किसी तरीके से तो nipple जाए बच्चे के मुंह में, and people are pushing the babies at the breast, and that not exactly breast refusal, but that negative association with that whole space starts happening. Although breasts are something that offer a lot of comfort to the baby. So somehow, because bottles have started coming in very early on, parents have started switching to bottles very, very early on, even without establishing breastfeeding. And then the latch becomes shallow. The baby is not able to latch onto the breast properly, but the mother wants to feed, really, really wants to feed. The family really wants to feed at the breast. And then there's a lot of pushing and pulling and tugging, and a lot of these things happen, which just starts making feeding a very, very stressful experience for the baby. So all we advise in that case is a lot of skin to skin time. If the baby is less like younger than 3 months, it becomes easier to do a lot of skin to skin time, and just giving the baby a break for 2-3 days. So sometimes just giving the baby a break works really well. So giving the baby a break, skin to skin. Sometimes tools also work. So if it is a bottle fed baby, although I'm not a big fan of shields, I'm really not a big fan of shields. But sometimes if needed, we introduce a shield at that point, and the baby latches onto the shield, and then we remove the shield. And so some things like at that point, what might work is very, very different for each mother.
Baby also says, give me a break.
Give me a break. Yeah. Yeah.
Thank you.
The breaks
Thank
generally
you.
work. And it's
Yeah.
easier to do that in under 3 months. At 3-4 month mark, the suck and swallow cycle is changing. Like babies are getting
Yeah.
preference. A lot of preferences
Agree.
are being shown. And at that very point, mother wants to introduce a bottle 3-4 month पे ही, क्योंकि 6 महीने पे काम पे वापस जाना है. तो उस टाइम पे बहुत ज्यादा गड़बड़ हो जाती है.
Very nice presentation. I must congratulate all of you. All the presentations have been great.
Thank you so much.
Thank you.
Can I ask a question? Meanwhile, Dr. JK sir is joining. What is reverse pressure softening? You have written in one of your comments, no? What is reverse pressure softening actually?
I'll be
You
very
were not-
brief
yeah.
with this, Priyanka. So generally, reverse pressure softening is something that works really well when you have very engorged breasts, right? And there are multiple videos on YouTube, on Lalish League, and all of these platforms, right? What you do is you try to gently roll the nipples, giving reverse pressure towards the breast, right? So reverse pressure softening. So this is just trying to get the nipples out and just applying a little bit of pressure in every position that there is around the nipple. And then multiple videos on YouTube that you can go ahead and check it out. So apart from cold compress, this also works very well for engorged and breasts which are red and not full of milk.
Okay. Great. Thank you.
Hello. I'm also having a question. I just want to ask how should we counsel the mother about cluster feeding? They're like कि baby feed करता ही रहता है तो at that time how should we counsel the mother? In...
Can I take this up, Priyanka? I think JK sir is there. I can take it in the comments also.
Yeah, you can take this question. No problem. Yeah.
Okay, thank you, Zainab ma'am, for the question. So babies feed, babies feed a lot of times. The good thing about cluster feeding is that it happens in phases. तो हम उनको ये बताते हैं कि हमेशा नहीं चलने वाला है. एक तो ये 3 महीने तक कई बार ग्रोथ स्पर्ट्स आएंगे, बच्चे एक आध हफ्ते के लिए बहुत बार दूध मांगेंगे. शाम को विचिंग आवर बोलते हैं उसको, जहाँ पे बच्चे बार बार दूध मांगते हैं, and it is actually helping you bump your supply. So there will be periods which will last for a week or two, and then again you will start seeing some cycles around it. सबसे ज़्यादा बॉटल और फॉर्मूला इंट्रोडक्शन क्लस्टर फीडिंग के टाइम पे ही होता है. तो मैं जनरली हम लोग फादर्स को बोलते हैं कि आप मदर्स को याद दिलाइए कि क्या आज उसने 6 बार सुसु किया है 24 घंटे में, पी किया है 6 बार? अगर किया है तो यू आर गुड, यू डोंट हैव टू सप्लीमेंट. Do not supplement if the baby is cluster feeding. You just remind yourself six count has been met. If you get tired, walk around with the baby, ask some other caregiver to take an expressed feed. Expressed milk aap nikal ke rakh do. You want to take some rest, you take some rest, somebody else can feed using a cup feeding. But the best idea is to feed at the breast all the time. But mothers do get tired a lot of times in those initial 3 months. So instead of putting formula in that place, you can have an expressed milk feed which has been just expressed, and you can just sleep for 2 hours.
Okay, thank you so much. Thank you so much.
TK sir, we are able to see your screen. Can you please check your audio once? We are not able to hear you, sir. Maybe you need to log in from the other device, or while joining the Zoom app, the audio has been switched off.
Priyanka, just one suggestion. Maybe we can also ask him to join using a phone as well.
Yeah, that's what I told him, that he can join with some other device. From phone also it is fine, sir. Your screen is visible, but you are not audible, sir. Or you can speak from your phone, sir, and the screen can be there like that. Meanwhile, any other question is there, we can take up.
Am I audible?
Yes, sir, you are audible now. Yes, sir.
Okay. My screen is visible, no? Echo.
Yes, sir, your screen is visible, but some echo is there, sir.
Actually,
Sir has to disconnect one audio. एक
Yes.
सिस्टम का ऑडियो बंद करना पड़ेगा.
हाँ, अब ठीक है?
हाँ,
Yes,
अब ठीक है,
sir.
sir. Better.
Okay. So extremely sorry for glitch. Actually, that was on my side. So coming to straightway to IMS Act. Dr. Cecily Williams in 1939 gave a historical speech, Milk and Murder, and which was given in Singapore Rotary Club, and she said that misguided propaganda on infant feeding should be punished as the most criminal form of sedition, and that those deaths should be regarded as murder. So concern was raised first time officially by Cecily Williams and regarding the misuse of formula feed and casualty caused by it in our infants and neonates. WHO took 40 years to recognize it. And in 1981, World Health Assembly was called, and it adopted international code on marketing of infant milk substitute, and in response to global infant mortality crisis. It curtailed unethical marketing by formula manufacturers. Another 10 years taken by Indian government and IMS Act was promulgated in India in 1992. And another 10 years was taken to improve it. So in 2003, we had amended act, which is we can say which is the complete act. So there are two acts, 1992 and 2003. So actually, 1992 Act had only restrictions for formulas which were pertaining to only less than 6 month baby, while amended act has covered up to 2 years age infant and children. And similarly, there was a freeness for publishing educational material for mother in 1992 Act, but in amended Act 2003, there is a total ban on incorporating funding, webinar, and literature. Similarly, infant food cereals enjoy relaxation and guidelines, but in 2013, there are complete restriction for promotion of any food which is made for less than 2 years of baby. In 2012, WHO showed again a concern, and World Health Assembly make a resolution 65.6, which endorsed the comprehensive implementation plan for infant, mother, and young child nutrition. And it again urges member state to put into practice as appropriate the comprehensive implementation plan on maternal, infant, and young child nutrition. So actually, there are certain international and national statute which are coming for preventing abuse of milk substitute. So coming to IMS Act, so there are basic three type of protection in there. Number one protection is protecting breastfeeding. So it isolates mother from commercial influences that falsely position packaged formula as superior to breast milk. Number two is a controlled distribution. By this, IMS Act regulates how infant milk substitute, feeding bottles, and infant foods are produced, supplied, and marketed. And third, it assures that only objective, scientific, and accurate information reaches healthcare worker and parents. So there are certain key definitions in Infant Milk Substitute Act. Infant milk substitute. So any substitute which is for powdered milk, which has a potential to replace mother milk. So it is come under infant milk substitute. Similarly, any food which may be taken as a substitute for mother milk, then it is also covered. So any food and milk which is less than 2 years is covered in IMS Act. Similarly, feeding bottle are covered. Promotion is taken to cover IMS, feeding bottle, infant foods. Health worker means any health worker which is engaged in care of mother, infant, and pregnant women. And healthcare system includes associations, pharmacy, private practitioner also. So key provision IMS Act 3, it completely ban the advertisement and promotion. So there can be no public advertisements, no TV, radio, print, internet, billboards, no commercial promotion formula and bottle, no incentives is allowed. It is strictly prohibited. No free sample, no discount, no coupons, no rebate can be given, and it is held illegal. And similarly, no display material can be placed which may influence the thinking of mother. So no poster, no play card, no promotional display for IMS product in hospitals, in retail shop, and in public places. Earlier there was incentive like Cerelac was given free with any other purchase, Ferex and other. This was the earlier picture, but it is strictly prohibited in 2003 Act. Similarly, there are pictures when promotions were there, which was apparent in ward. So there is prohibited that no one can display posters, calendar, or any promotional material. No brand promotion in hospital, clinic, chemist shop, or any healthcare setting, or no visibility, no promotion, and no influence. Similarly, advertisement cannot be sent in print media, electronic media, and any other method. Coming to section 4 and 9, there are key provisions that insulation of the healthcare system, it is also taken care. So no financial incentive to healthcare worker, no gift, no cash, no free sample to medical staff, no commercial sponsorship for doctors, and doctors are barred for funding for conferences, researches, and grants. And no corporate content should be displayed inside clinics and hospitals. So no sponsoring. Actually, these are the pictures which shows that there were sponsored talks and conferences. And these are the pictures which shows that there was a time when donation of products of educational material and equipment was there. Section 6 says that there is a provision and there is a strict labeling and packaging mandate, and we should ensure clear product information. So mandatory warning should be there, and it should be visible that breast milk is best for your baby. No picture of baby or glamorizing graphics can be displayed over the tin or boxes, and information should be printed in explicit way, and there should be clear and comprehensive product details over the packaging material of the formula milk. It was the earlier picture when cartoons, babies' photos were seen among the formula feed or formula out of infant foods, but it cannot be allowed. Similarly, there are regulations on sale and personal in section 5 and 8. So, as section 5 says that no direct to consumer contact. So, no sales representative can approach pregnant women or mothers and even NICU. So, direct contact in public places, community, and hope is strictly prohibited. Limits direct marketing pressure on new parents. And section 8 says that no salary, bonus, commission cannot be tied for formula sales. So company can gives bonuses for extra business. And sales volume of feeding bottle is also excluded from incentive pay, and it prevents high pressure sales. So these are the provision which should be strictly followed. There were earlier picture which says that there was a photo of bottle, and these are the earlier picture. Then the days are gone. Coming to penal provision, so section 23 says that any violation of sections mentioned attract bailable and cognizable offense. What is bailable? That bail can be granted, but cognizable offense that police may arrest without warrant. And section 20 says that cognizable offense for cognizance may be taken by police, by enforcement officials, and special NGOs like BPNI are authorized for taking cognizance, and they may monitor and file complaints directly to the police or court. Strict legal penalties are there. If anyone who violates the sections mentioned in the IMS Act, maximum 5,000 fine can be levied, and imprisonment up to 3 years may be awarded. So actually, there are important difference between IMS Act and standard criminal law. Actually, cognizable is mentioned in IMS Act also, and it is mentioned in CRPC and IPC also. But actually, in IMS Act, cognizance is restricted. In normal offense or criminal offense, cognizance is taken state by police and court, and police may arrest straightaway once a cognizable offense is committed. But in IMS Act, cognizance will be taken only by authorized NGO or any authorized officer to initiate prosecution. So cognizance is restricted in IMS Act. These are the pictures, and in this there was MCI MCI regulations were violated, and 9 months 9 month removal was there for the doctor who violated the sections. So law has been made, but how impactful it has been. So there is a dual reality. Of course, success has been there. Eradication of mass market ads is there, because we don't see any advertisement in print media or electronic media, and by the grace of this, exclusive breastfeeding is also increased, so by 38%. So these are the legal success, but there are challenges also. Certain medical sponsorship are still going on, and growing digital and sales and e-commerce is posing great threat to IMS Act. Impact is that growth of IMS industry is going on, and actually it is presently having market of 10.49 billion, and it is expected to reach 13.83 billion US dollar. So actually growth is still there. You may see the bars which shows that there are steep growth, and the growth is annual growth is 5.78 CAGR, and infant and 55.3 is share is only for infant formula. So economic impact is visible in India. Actually, data says that total economic impact is 1.1 lakh crore loss only because of infant formula milk. In divided in three categories. Human capital loss is 1 lakh crore. It means actually it is calculated that children who are not breastfed are estimated to lose nearly 36.4 million IQ points collectively. That reduce the future productivity and workforce. So annually, 1 lakh crore cognitive deficit, low IQ, premature mortality is there. Similarly, healthcare system is also burdened by violation of these acts and promotion of formula milk. About 800 crores is expenses which are taken care by healthcare system, which may be prevented only for breastfeeding. But infant formula milk is posing so much threat. Similarly, maternal health cost is also there for breast cancer, ovarian cancer, and type 2 diabetes. So it is a summary table which shows that total annual national loss is 1.17 1 lakh 70,000 crores, and national family spend formula is 25,400 crores, and the cost per families per month is 3,000 to 10,000, and cost per family per year is 36,000 to 1.2 lakhs. So it is the huge expenses on national and family income and family growth as well. So actually question arises, so such stringent act is there, but how company manage to violate the IMS Act? So there are various ways. The researches are sponsored by such companies. These are pictures. There's conferences are still being sponsored. We all know that who is sponsoring conference and who are attending the conferences, and CMEs also. And there are offering sponsorship for conference participation. And there are certain companies which promote by other way. Actually, this is the picture which shows that one company has a talk or has a video that what should we feed our babies in order to improve their immunity. So how can formula feed give more immunity than mother milk? So basic awareness statistics is also important. Doctor and pediatricians are aware about 61.7%, but awareness for nurses, midwives is quite low. It is one-fifth. It is a 21 to 28%. Similarly, chemists and pharmacists are also one-fourth, 25% aware about IMS Act. So violation is there by doctors, midwives, staffs, and chemists also. So we have to take interventions to close the gap. For We have to make targeted fact sheets and policy briefs. We have to make curriculum integram, and IMS Act should be taught in MBBS and curriculum and nurses also. And the hospital wall campaign should also be run by our government and by our associations. There are constraints in IMS sector actually because IMS sector has a very challenges. So we are now going to discuss what are the constraints of IMS sector. So regulatory compliance challenges, there are misbranding because they are branding in a hidden way. Their hidden message, promotional language is altered or changed. So there is smartness by the companies also, and sponsorship or workshops and health professionals is still going on, and gift samples are still going on. We are all aware. And implementation bottlenecks are also there because there is weak enforcement of IMS sector. There are limited public awareness. There is literally no funding for IMS sector implementation. And there is an inadequate monitoring system because only certain certain association like BPNI are untested, but it is not enough to take the challenges and challenges in the illegal proceeding as well, because the penalties are very lenient. Fines are very small. 5,000 is nothing because we have seen that in BNS actually fines have gone up, shooted, but in IMS it is not there. And similarly, investigations is very complex. There is least minimal conviction rate and judicial delays, all know. So what are the ways to make IMS Act effective? So we should modernize the law for the digital marketing because we have seen that this is era of digital marketing. So there is a cross-selling. So we have seen that when we go for online purchasing, there is a automated, frequently brought together pop-up pop-ups are there. So when we see when he search for diapers, it automatically shows that there is another product like infant formula which is maybe needed for you. So similarly, we should ban this cross sellings. Similarly, we should enforce strict online price uniformity because price uniformity is not there. Different pricing is there, and there are apparent off on online marketing. And we have seen that section 8 says that we cannot offer any discount or we cannot give any incentive for sale, but actually in online it is not there. Similarly, there are influencers which should be regulated because they are making own content, and they are not scrutinized and they are unchecked. Similarly, we have to upgrade the penalties and deterrence. Actually, penalties 5,000 is minimal. It is nothing. So it should be, our suggestion is that it should be replaced with dynamic revenue like financial penalties because actually the companies are making a lot of profits. So so penalty should be related to their margin of profit. It may be 1%, 2%. And there should be corporate executive liability because actually corporate liability is not there. So which it should be provision that the authorities or marketing directors and advertising agency should be make criminally liable in IMS Act. Similarly, streamlining enforcement mechanism should be there. And actually, we have seen that there is a restricted cognizance is there. So actually, there should be direct cognizance as like BNS or IPC, and police should be empowered to have direct FIR. And similarly, there should be a made national digital reporting portal, because reporting is very difficult. Reporting is taken only by few companies which are recognized under IMS Act and or government. So like BPNI. So reporting portal should be there, in which anyone can upload the violation. Can upload photo, screenshot, and location of such violations, and food safety officer can take direct effect. Similarly, fortifying the healthcare network and professional ethics should be there. There should be mandatory institutional vetting panels. There should be ethic committee. There should be compliance oversight, ethic review, sponsor vetting, conflict of interest checking. And IEP has taken initiative, and in the last directive of 2015, there was a written legal under the provision of legal written legal undertaking from the event sponsor, that there is a no formula company is sponsored in that particular case. So undertaking should be there, and directive from the association should be there. Similarly, institutionalized nurse and pharmacist training should be there, because we have seen that doctors are still aware of this act, but nurses are largely not aware. So there should be CME hours for doctors, and similarly for nurses training also. So nurses training and retail pharmacists should also be taken, and the syllabus should contain the IMS Act in pharmacist and nursing curriculum. So that 70% baseline knowledge deficit can be covered. It is a very important regulation made in 1995, Cable Television Network Regulation, and Rule 7 says that advertising code, this advertising code prohibits advertisement that violates any law, including IMS Act. So actually, any television or any media which is coming under that act cannot show advertisement which are prohibited under any law in the force. So IMS Act has got protection in this also. These are the efforts which are seen by Government of India. Government of India has written letter to ICMR. Secretary has written letter to state governments. State government have taken action. They have issued the letters. So the government has taken a lot of efforts, but there are still very scope. Now I am touching few case laws which are important, and actually there was a case law with Akash versus Nestle India. In this, code says that consumer warning must be visible. So there is a provision that breastfeeding is best for health. Mother feeding is best for health. So it should be visible. It should be written in bold, and it should be made available in regional languages. So it is a very important judgment, and it established mandatory multilingual labeling. Similarly, Rooney court order judgment, and it gives the order that sufficiency of suspicion for trial initiation. So if there is any suspicion that there is violation of IMS Act, then court may take the cognizance. So there is no legal foundation that perfect evidence should be there. So even on slight suspicion, trial may be initiated. So this is important judgment. Similarly, ICMR hospital trials, in which there was absolute ban on the corporate funding was imposed, corporate funding on research. So in this, ICMR has been asked to send a notification for research. So there is an absolute ban on corporate funding on the research. These are the personal case law which have been taken against healthcare providers. We should be aware of that. The one is 5 private hospital research ban case. In this, 5 private hospital have research, including Cloud9, Manipal, Sri Gangaram, CMRI, and ICH. And there was the issue that these research was funded by IMS company. So actually, this was screened by BPNI and via ICMR registry. Then enforcement was taken under section 9.2, and this research was stopped immediately. We all know that Dehradun Pediatrics Summit enforcement in which a pediatric health summit was sponsored by Award Company. And in this case was reported by police and DGP Uttarakhand, and Union Health Secretary has taken cognizance, and it was cancelled. And this is important case, the BPNI versus private nursing home serving complaints. And in this, it was seen that nurses or doctors are allowing prescribing commercial formula without any clinical need. So it was enforced in this case that there should be documented clinical need for prescribing formula, and it should be documented, because in absence of such apparent clinical need or documentation, the doctors may be held, or nurses may be held for violation of IMS Act. The core matrix is accepting corporate fund for clinical trial is absolutely prohibited. Sales representative can't distribute branded growth chart or pads, and attending manufacturer sponsored nutrition cannot sponsor webinars or tours. So actually professional, earlier we have discussed that government has taken action. These are the action of professional associations. So IAP has taken a step, and IAP has issued official warning that we should, any member of Indian Academy of Pediatrics can't take sponsorship from any IMS company, and any branch should take a declaration in written that such company has no IMS formula in their portfolio. Similarly, NMC has made regulation that doctor may lose their license to practice if a violation of IMS Act is there. So actually, we have here. These are the last two slides. Actually, we have seen that there was an issue that in IAP guideline, which was issued in 2025, it was said that all the IMS companies, a list was given in the circular, IAP circular, that such company cannot be taken, cannot give any sponsorship. And in that, it was also mentioned that these companies and sister concern of these companies. So actually, it is important to mention that as per law, sister company cannot be held for any act committed by parent company. These are the case law: Balwant Raj Saruja versus Air India Limited, Cox King Limited versus SAP India Private Limited. So these are the Supreme Court case law. So sister concern cannot be held liable for the parent company act. So legally, sister company are not prohibited from taking from one act which was taken by parent company. But as IAP has issued circular, so circular is there. So any document guideline is there, so it may have binding effect. So I may say personally feel that it is actually maybe on ethical basis, but it is not legally sound. So if such circular is there, we should abide that private parent company and sister company should not be taken sponsorship unless until IAP revises its circular. These are the horizontal immunity in the IMS Act. Actually, these are the same cases in which a sister company was given immunity by the act of parent company. So take-home message is there, how IMS Act can be made more effective. So we should modernize the law. We should update for the digital marketing. We should ban algorithmic cross-selling, enforce price uniformity, and regulate surrogate influencer marketing. And we should upgrade penalties and deterrents. We should revenue linked penalties, like 1 to 2% of annual turnover, corporate executive liability, making non-compliance financially and personality costly, streamlined enforcement, permitting standard FIR. There should be complete cognizance, not the restricted cognizance. There should be national digital reporting portal. There should be faster, easier, and citizen driving enforcement system. And we should fortify healthcare network and ethics. monitoring institutional vetting, ethics committee should be there. We should have training of nurses and pharmacists as well, and we should embed IMS Act in CME and curriculum. Like you have taken, you have included IMS Act in your talk. Thank you. And this is the last slide in which uh, I've written my I've given कविता लिखी है ये, और मेरे ही शब्द हैं ये, कि गंगा जल सा पावन तेरा, दूध नहीं माँ अमृत है, माँ के आंचल की अनुपम निधि मातृत्व का शुभ व्रत है, लाड़ दुलार तेरा प्यार पाने को मन ही नहीं हरि भी नत है, ममता तेरी काल जयी माँ यह सत्य नहीं यही शाश्वत है. Thank you very much.
Thank you, sir. It was a very insightful session, and it is a very nice poem. As we come to the conclusion of this enriching workshop, I would like to express our sincere gratitude to our guest of honor, Dr. Milind sir, for his valuable presence and guidance. And I extend heartfelt thanks to Dr. Ashish Prakash sir, Dr. Akash Pandita sir, UP NNF Nutrition International, the National Health Mission Uttar Pradesh, and all our distinguished faculty members for sharing their knowledge and practical experience. And my sincere appreciation also goes to all the candidates who have joined today. Let us leave today's workshop with one commitment, that every mother will be heard, every breastfeeding difficulty will be addressed with empathy, and every baby will receive the best possible nutritional beginning. Thank you to all the faculty for joining today. All the presentations were wonderful and very practical. Thank you.
Thank you, Dr. Priyanka, for conducting the session so well. And
Thank you,
my
sir.
thanks to all speakers, all dignitaries, Dr. Milind, and the faculty from various places, the Nutrition International and National Health Mission. I think it was, as what stated in the beginning, that only 50%. It was a very good example. And I wish to quote it all over again, that if you only do 50% of the syllabus, you cannot score 100% marks. So let us, for all future endeavors, concentrate on covering the 100% solution. Looking forward to such collaboration with the governmental organization, all the medical colleges, truly well represented in this session also. Madam from KGMC and sir from Kanpur. Thank you so much, Dr. Akash, Dr. Priyanka, and everyone.
Thank you, sir. Have a wonderful evening. Thank you.
Thank you.
Thank you, everyone.
Thank you so much, everybody. Special
Thank you. Thank
special
you.
thank
Thanks
you to
for
Dr.
inviting
Pandita.
and giving opportunity to interact with you. Thank you. आखिर में जाते हैं तो सब थक गए. ये प्रॉब्लम क्या, लैपटॉप में प्रॉब्लम है क्या, कहाँ है?
Dr. Priyanka, shall we drop off?
रोज